Вітаю вас, шановні.
Good morning, dear colleagues. Despite the air raid alarm, we have a lot of people now registered and present at the conference. We continue with the second day of our conference related to management of patients with tuberculosis, implementation of innovative solutions in practice, organized by the National Institute of Physiology and Pulmonology. And today we'll have 3 sessions followed by a master class. The 4th session today was moved to the first session, and we will be talking about partnership support for struggle against tuberculosis in Ukraine. The fifth session will be about microbiological tests, and the 6th session about differential diagnosis of tuberculosis and other lung diseases using modern algorithms of diagnosis and treatment. After the main sessions, we will have another master class that is called Best Clinical Practices of Tuberculosis Management with accompanying lung diseases, and you will receive additional points for it. And then yesterday we had a lot of questions concerning impossibility to join the master classes, and we would like to mention once again that after the end of the main sessions, you'll have to leave the conference, and then you will have to use another link to join a master class. The link that was sent to your email that you indicated when you registered for the second master class on the 14th of January. So if we don't have any organizational issues to be resolved now, I will give floor to today's moderator, Svetlana Leontieva, project manager for supporting effort in the sphere of fighting tuberculosis of the PATH International Organization. Good morning, dear colleagues. Can you hear me when I speak in the microphone? Okay, so good morning. Once again, in Kyiv, we have a continuing air raid, and this demonstrates how unbreakable the Ukrainians are, because despite of the explosions in the capital city, in Kyiv now, despite these desperate times, the National Institute of Physiology and Pulmonology, named after Yanovsky, continues its regular annual national conference on management of patients with drug-resistant tuberculosis, and we are ready to share the most innovative state-of-the-art practices of dealing with the cases of drug-resistant tuberculosis. And our international organization, PATH, cooperates with the National Institute of Physiology and Pulmonology for 20 years now. We implemented various projects financed by the USAID and other international donors. We implemented these projects in cooperation with the National Institute and with the Physiology Service of Ukraine, in cooperation with the Center of Public Health of Ukraine, with the Ministry of Health, and of course with our regional, district, state administrations, departments, and offices for healthcare, and in cooperation with you, our dear doctors and specialists. For many years, we've been cooperating for overcoming the tuberculosis epidemic in Ukraine. During this session, during the second day of our national conference, we would like to tell you a little bit more about the results of implementation of a 5-year-long project for supporting effort in tuberculosis, in the sphere of tuberculosis control in Ukraine, funded by the USAID, which is implemented by the PATH. The project started in October 2019 and it will be ended in September 2024. So today now we are in the 4th year of implementation of this project, and the name of this conference now the air raid sirens are silenced, so it's the end of air raid alarm. So let's stay together and glory to the armed forces of Ukraine. Thank you, dear army, for the end of the air raid. So the name of today's conference is related to innovative approaches of management and control of drug-resistant forms of tuberculosis. And now we are going to share with you the outcomes, some outcomes of this project, because it's aimed at decreasing the burden of tuberculosis in Ukraine through prevention, early detection, and the use of the most innovative approaches to treating tuberculosis with accompanying diseases, and drug-resistant forms of tuberculosis. And as a coordinator of tuberculosis programs in the PATH, and I am the senior advisor on capacity development for the PATH. I've been working with them for 18 years now. I would like to start my presentation now, by Gunta Dravnitsa. Gunta, we see you. Hello from the National Institute of Physiology. We see you on the screen already. Gunta is the director of the project for supporting anti-tuberculosis effort in Ukraine. And I would like to say a couple of words about Gunta now. She has a unique expertise because she can combine both many years of experience of clinical management with experience of project management. For many years, Gunta worked in a collaboration center of the WHO on MDR in Riga, in Latvia. Gunta also worked in the Fund for KNCV, Tuberculosis Foundation, and starting 2020, Gunta joined our international organization as a director, as a project team lead. So Gunta, over to you. Olena, Volodymyr, and myself, and our colleagues from the National Training Center who we supported by the USAID. So we are glad to see you, and over to you. Thank you, Svetlana.
In English, I hope that's fine for you. I hope you can hear me, Svetlana.
Yes, we can hear you well. And thank you.
Sharing the screen. Can you see my screen?
It's in process now. We see you now. And now we are going to show your screen. Yes, now it's on the screen. Yeah, we can see your presentation. So over to you.
Thanks, Sveta. Many thanks, colleagues. And first of all, many warm greetings on the anniversary to our colleagues from the Institute. And as Svetlana mentioned, and as you can clearly see on the video advertisement of the conference, us and all our colleagues have been together with colleagues from Institute for years. In all pictures, you can see colleagues from National Program from Institute and from organization PAS. As Svetlana mentioned today, we will discuss briefly key highlights from our project. We cannot show everything we do a lot, but we wanted to show you few highlights, and I will just give you an overview, and other team members will give you more details on each of the subjects. So briefly overview achievements and what do we plan to do next. Project is funded by USAID, so it's funded by US government. As Svetlana mentioned, we started in October 2019, and we plan to continue project till end of September 2024, but I can tell you that we are already discussing with our donor, with USAID, that there could be project extension for 1 more year, but we don't have confirmation yet. So it could be 24, it could be 2025. Initially, we started support in 12 regions. You can see on the map on all regions with whom we collaborated. Many of those regions were our partners, past partners already with previous USAID funded project Challenge TB. This covered 53% of the population of Ukraine, around 22 million people. Initially, we had 4 project objectives. But due to the COVID in May 2020, we agreed with donor that we will add objective number 5. So first objective is building staff capacity. Our work through training centers, through Association of Family Medicine, many other activities. We are supporting early diagnosis of TB and also very importantly of latent tuberculosis infection. We are working hand in hand with you on quality of care, our clinical mentoring, different innovations for diagnosis and treatment of childhood TB. We are also supporting advocacy. We are providing patient support, stigma reduction activities. And as I mentioned, last objective was added just in 2020, in May 2020, due to COVID. And Roman Rodina, our colleague, will tell you more about these activities. Regarding objective 1, just to highlight you achievements, as I mentioned already in previous projects implemented by PAS, we helped the country to establish regional training hubs. So there are 3 training hubs which are supported by PAS, by project. One is in Dnipropetrovsk, one is in Lviv, and one is in National Institute. Since those 3 hubs have official registration in government-regulated system of continuous professional development, hubs conducted 25 trainings and 10 seminars, and in total, more than 2,000 healthcare workers were trained. We believe this is a sustainable system because all participants received state-approved certificates. Dnipro in Lviv provided trainings on current approaches as per latest WHO recommendations on management of drug-sensitive and drug-resistant TB cases. National level hub in Kiev has been currently providing course 10-day masterclass for TB specialists on MXDR TB case management. And in addition, Dnipro Hub conducted trainings and seminars in classrooms and online on securing infection control measures during COVID vaccination. And Roman will tell you more. And if you have some questions, please don't hesitate to ask. Besides trainings is not the only activity which we conduct under Objective 1. Especially we were motivated by COVID pandemic when in-person trainings were limited. We developed multiple video instructions, video SOPs, video lectures on different topics. You can see all our lectures and instructions on YouTube channel, on ECG monitoring, on the use of Smartbox, on stool testing, very nice instructions which we developed together with our KNCV colleagues. Everything can be found there and we shared with all training centers and partners. Under Objective 2, just to highlight what we do, in July 2020, we started transportation support. Again, it was sort of catalyzed by COVID. Initially, we planned to just pilot it in 1 or 2 oblasts, but COVID proved that we have to do more. So we initiated multifunctional transportation system. It doesn't transport only diagnostic specimens for TB. It transports also specimens for HIV diagnosis, for monitoring of treatment safety for TB and HIV, and also is helping to deliver medicines to the district level. And again, my colleagues will tell you more details, but just since we started, the system delivered 166,000 specimens, and 25% of those were for TB diagnosis. So as I mentioned, we are supporting also diagnosis of HIV and treatment monitoring for TB and HIV. We are very proud that we sort of revived the use of mobile X-rays. And just yesterday we discussed with our colleagues from Geneva how we started, how proud we were with the first pilot in Geneva region, and we will be back on track. So we helped regions to repair, to upgrade existing mobile X-rays. We procured up-to-date portative and mobile X-rays for other regions, and Elena Pavlenka will tell you more how many in which regions. But here you can see just photos. You can see on the left photo of our brave partners from Kharkiv, from the organization who helped to upgrade the X-rays. We are very happy that they are there. They are working despite all the attacks. It's not just procurement and repair. It is a lot more. We are discussing algorithms. We are supporting development of routes for visits to remote areas. And as I mentioned, Lena will tell you more. We are also focusing on diagnosis and management of latent TB infection. We established collaboration with two private laboratories and started testing more than a year ago using Quantiferon tests. More than 3,500 tests performed. I think by now it's close to 4,000. We discussed with our UCPH colleagues and agreed that we will continue this support also next year. You know that UCPH is also procuring Quantiferon tests, but they have different mechanisms. They are procuring consumables for Quantiferon tests. We believe that collaboration with private laboratories is efficient because regions don't have to worry about maintenance, about expiration of consumables, etc. It's just provision of services. Of course, it's not cheap, but it works. And we are also very proud to see that proportion of shorter TPT regimens is increasing, and that the regions are using more and more regimens for drug-resistant TB prevention, which is crucial for situation in Ukraine with many people having drug-resistant TB. I think this is the topic which you have heard the most. Of course, in numbers, it's maybe not so powerful, but we are helping the most vulnerable group of our patients. Those are little patients for whom previously there were no really patient-friendly methods of diagnosis. So we introduced stool testing using Expert Ultra for small children, mainly children under age of 5, but you can see on the chart below that there are also children 12, 13, 14 years old, those who cannot produce sputum. And I'm very proud of the slide chart on the left side where you can see the drop in March after Russian attack. But immediately in April, regions were back on track. They were providing testing despite all the attacks and all the challenges in regions. And you see on average 11% of samples were positive. We are also thinking about the future, and many thanks to our colleagues from laboratory, from institute, who agreed to take this task and think about the future. We are introducing genome sequencing in institute's laboratory, in National Reference Laboratory. We provided series of trainings, and provide supportive supervision. Our expert, Alexander Chernov, will tell you more today in one of the sessions in the afternoon. So please connect and follow Alexander's presentation. But this is the future diagnostics, which will answer all questions which are needed for clinicians to prescribe the best regimen and also for program surveillance. Of course, we have to talk also about awareness, about advocacy, about stigma reduction, and there are multiple activities supported by the project. You see a TV series on Apostrophe, the first series were dedicated to childhood TB. Many topics, diagnostics, treatment were covered in this. We also are very proud to have a book which helps children, young children, to understand what is this, what is TB, how to deal with that, and you can see a nice cover. Book is available. If you want some samples, please let us know. We will make sure that you get it. For year 4, as you can see just in photos, we will continue all interventions which I mentioned before. We are also, because of the war, we are providing food support. Several regions asked for support. We are supporting fuel for generators. We will continue digital adherence technologies, stool testing, X-ray screening. All those activities were discussed with the donor as UCPH and with, of course, with regions, because those are our main partners, and we will continue support. Geographically, we expanded since July to 5 new regions. You can see on the map, it's Zakarpatska, Chernivtska, Vinnytska, Volynska, and Rivnenska regions, because of war, additional support was needed. So in those regions, we are discussing, planning, and clarifying what exactly is needed. We will focus very much on active case finding, including use of innovative approaches. We will work closely with primary healthcare facilities, mobile X-rays, fast strategy, screening about X-ray population, continue support on diagnostic network to improve TB case detection and, of course, diagnosis and management of TB infection. And of course, we will continue to improve quality of drug-resistant TB management. We will continue supporting supervision and clinical mentoring, quality of childhood TB patient management, including up-to-date patient triage. You know, there were several new recommendations released this year, and we want to make sure that also for children, the most up-to-date practices are used. Thank you very much for attention. And you can see I'm based in Riga now. You can see our Monument of Freedom. And actually, when you walk in Riga or any other city in Latvia, sometimes it's difficult to say, is it Latvia or is it Ukraine? Because Ukraine flags are everywhere. Many thanks, Svetlana.
Thank you so much, Gunta. It's so nice to see that our yellow, blue flags can be seen everywhere in Riga and here in the National TB Hub as well, from where we have our online conference, which is broadcast live on the YouTube channel. So you can join the National TB Hub channel to watch the national conference on management of drug resistance forms of tuberculosis. Gunta, thank you so much that you mentioned that our project is ongoing and there is a possibility for continuation of the project till 2025 in September. So our cooperation continues, and really those innovative approaches to prevention, to early detection, and to proper treatment of tuberculosis, including drug resistance and co-infections. This is what our international organization is doing within the framework of the projects for supporting effort on combating tuberculosis in Ukraine. So thank you very much for your wonderful presentation. We continue our conference, and we thank you for joining us from Riga. Thank you for your warm words for the Ukrainians. And I think Gunta is already 50% Ukrainian, because we receive this immense support and we have this positive cooperation with PATH for many years. We cooperated and now Gunta works for the PATH. So we've already painted your blood with yellow and blue already. Thank you, Gunta. And let's continue our session. Now I would like to introduce Roman Rodina, who is also a coordinator of programs. He is our project manager for supporting effort on combating tuberculosis in Ukraine. Roman has 20 years of experience of work, and he has expertise in the sphere of public health, epidemiological control and oversight, response to challenges in the public health sphere. He has many years of experience introducing and implementing activities in the infection control sphere. So he's an expert who joined our organization. Roman was supposed to join us online. Is he with us? Not yet. Okay, yes. So we will show Roman's presentation, but meanwhile, I would like to say that when we started we entered the period of restrictions related to COVID-19 epidemic, we adapted our project activities very quickly to the situation. And at that time, it looked like extreme obstacles for tuberculosis control. But starting February 24, 2022, when this full-scale invasion of the Russian Federation started, which is still ongoing, our project was forced to again adapt to the wartime reality. And now we are working not in the 12 regions where we started our project. Now we cover 17 regions. And Roman's presentation is about it. Yes, we are about to show it, and Roman will make his presentation about our project activities in the wartime conditions. Greetings, dear colleagues. My name is Roman Rodina, and I am the project manager of STBCU project. And I will tell you a little bit more about the challenges faced by our projects during the war. And the first challenge was a huge number of internally displaced persons who require medical assistance, including vaccination and vaccines against COVID. On this chart, you can see the dynamics on the change of the number of IDPs according to MOM. You can see that 7 million account for approximately 16% of the Ukrainian population. They became internally displaced persons, and all these people, they need medical care. But the situation in the sphere of COVID-19 epidemic, this is one of the activity areas of our project because we provided response to the situation with COVID-19. And this diagram shows the number of registered COVID instances in 2022. You can see that in the beginning of the year, we had this outburst of infection. Then after the beginning of the war, the number of registered cases decreased dramatically. On the one hand, looking at this line, you can see that it's season related after the end of this respiratory disease high season. But on the other hand, we had limited possibilities for testing, for healthcare. People were migrating and displaced, and then there were other dangers caused by the war. We saw that more and more people did not go for medical assistance, did not go to hospital, and then the number of registered cases and instances decreased. And we understand that the real number of COVID cases was much higher than shown on this diagram. So this is another problem that we encountered in terms of assessment of the real situation with COVID in the regions. Other problems you can see them on this slide. They are related to the spread of COVID-19. The challenges included the limited access to healthcare, especially for IDPs, especially those who stayed in shelters or collective centers. Huge problem was the loss of contact of IDPs with their family doctors, and then they were not able to receive the information concerning their vaccination status, no access to documents. So those people were believed to be non-vaccinated because they had no documentary confirmation of the fact of vaccination. So there were changes here as well. Another problem was damage of healthcare facilities in hostility areas, and that prevented doctors from provision of healthcare to people into the full extent. Then we had host communities, host districts in the central and western parts of Ukraine, and there was overload and extremely increased burden on family doctors, and the number of patients increased by 1.5 or even 2 times. So our project refocused its activities, and we started to support monitoring visits to the places of IDP residents with multidisciplinary teams. We had specialists in public health, epidemiologists, primary medical care specialists, and neuro specialists. We also involved a team of vaccination doctors, and you can see on the photo below, we provided vaccinations in the place of IDP residents or stay. We also involved specialists as necessary, involving psychologists, and we even involved people from the State Service for Emergency Situations that shared with IDPs the information related to mine safety and telling them about what they have to do if they see any suspicious objects. During these monitoring visits, we provided information to IDPs about prevention of infectious and non-infectious diseases during the wartime, and information about other risks and threats that can be faced during war, such as radiological, chemical hazards, and other types of threats. Then we organized vaccination of IDPs, and a special brochure was designed with all the data related to prevention of diseases and with information about what people have to do when they are in dangerous situations caused by war. So these brochures were distributed to IDPs during our visits. Our project also focused its activities focused on the needs of prevention and control centers in the regions. As you can see on this slide, we procure generators, laptops, tablets, mobile phones, and refrigerator bags so that the Centers for Prevention and Control of Diseases can work during war and in the conditions of limited funding and increased risks. A great achievement of our project was that we procured, and now during the war, we implement a laboratory information system uniting the laboratories and the centers of public health in Ukraine. So we will create a system that will enable us to monitor the status of the laboratory system, the condition of equipment, and so on. This system will also contain a lot of information about the available resources for laboratories and about the situation with human resources. Our project also supported validation of biosecurity cabinets, which is an important element of ensuring biological safety in laboratories. Another achievement of our project, and it's real achievement of our project, so we piloted a new type of epidemiological control for the country, which is monitoring of drainage waters. This is a separate area of epidemiological control that enables us or gives us a possibility to see the content of sewage, drainage waters. So a sick person immediately after being infected starts emitting bacteria. So in the very beginning of this period, the person starts emitting the virus. And if we have enough time to detect this virus in sewage water, we can start functioning proactively and restrain the process of the spread of the virus. So you can see on the pictures the process of sampling waters in 4 regions of Ukraine, and we are going to continue implementing these epidemiological control activities. We are going to cover other regions as well, and eventually the entire territory of Ukraine, and we are going to support the Ministry of Health of Ukraine in its efforts, and we hope that this type of control will provide a lot of health during the wartime in terms of the virus control. Another activity area of our project, we've been implementing it since June 2020. We organized a system for transporting of biological materials and drugs. So we provide support in transportation of samples for diagnosis of tuberculosis and transportation of drugs. On this slide, you can see that before the war, this activity was carried out in 12 regions, in all project regions, and during the war we continue to implement this activity area in 8 regions. In November we resumed our activities in Mykolaiv region, and during this period since June 2020 we organized approximately 4,000 visits and covered approximately 1 million kilometers. On this slide, you can see the number of samples that were delivered with the help, with support of our project. We are talking about diagnostic samples for diagnosing tuberculosis, and we found the cases of multi-resistant to tuberculosis, and more than 27,000 of monitoring samples were delivered. And in the bottom, you can see that 5% of samples delivered for HIV diagnosis, 5% were positive, and this number increased since the beginning of the war. On this slide, you can see information about the number of people who received treatment as a result of support for transportation of drugs from our project. You can see that almost 100,000 deliveries were carried out. We're talking about delivery of anti-tuberculosis drugs and antiretrovirus therapy drugs. Since the beginning of the war, you can see a dramatic increase of the number of people who received these drugs with the help of our project. Another innovative activity was implementation of improved approaches to detection and treatment of the TB patients at the primary levels. This activity started in 2021, and despite the difficult situation in Donetsk Oblast, we continued our work during the war, and the list of activities that were carried out you can see on this slide. So we analyzed the obstacles for family doctors in terms of detection of TB patients. We organized training for medical professionals. We changed and amended job descriptions so that the doctors can detect TB instances more actively, and then respective order of the healthcare department of the this military civilian administration. The order was approved, and then terms of reference were developed for finalization of the medical information system or health information system, and we enabled doctors to enter in screening data into this system so that they can have more complete information.
You can see the result of this work on this slide. Within 2021, we could increase their diagnosis of TB on 17%, and also that the term between the first address to the choosing the treatment, that's like it's shorter, and also during the war, we were able, with the support of family doctors, we could find 113 patients with TB, and all of them are getting treatment now. So almost 400,000 people who had contact are in the registry, and there were some cases among them as well. Another direction of our work, that's also innovation, that's implementation of digital technologies for adherence to treatment. That's SmartBox and VideoDot. Basically, these technologies, they allow to track the adherence to treatment. And when the patient is opening the box with drugs, then this box, through a special app, sends the signal where doctor sees that the patient took these drugs and they continue treatment. It was very useful when there were limitations introduced by COVID and also during the war. But during the war, you can see that we have new challenges. And regardless, we managed to continue implementation of these digital innovations, even though we had to go through evacuation, the number of IDPs, air raid sirens, problems with transport, psychological barriers. But you can see these green squares. It means that the person is opening a smart box and the person takes drugs. So adherence to treatment was really, really high. And on this slide, on this graph, you can see about adherence. This is a data as of December. And adherence to treatment was more than 80%. And some months they were even higher than 90%. That is a very high result, which we managed to achieve. And on the right, you can see the geography of this implementation. And so in lilac, you can see different colors, yeah, like what they mean about our implementation. Thank you for your attention. Thank you very much, Mr. Roman. Roman had a nice mission, but not easy mission, to cover all the approaches of PATH as a project of USAID. So we started to work in this project of support TB efforts in Ukraine project during the war. But now I would like to give the floor to my colleagues who are here with me during live stream and who came here regardless air raid siren which we had in the morning in Kyiv, and we even heard some explosions. But we really wanted to come here and to be here offline. Now I would like to give the floor to Ms. Olena Dyuhina, who also the coordinator of program of PATH, manager of the project of support TB efforts in Ukraine. And I would like to say a few words about Olena. First of all, Olena has many years of experience of treating and managing cases. So she was a physiatrist in in TB hospitals in Odessa region. And Ms. Olena has experience how to treat tuberculosis and management of TB programs on the national level. She worked in a state organization of the Center of Public Health, and since 2018 she joined our international organization, and she has been working on STBCU project now. And now we would like to talk about innovative approaches for children, diagnostics for children. So please open the presentation. And let's talk about testing feces for TB diagnostics for children, which we are implementing now as a part of the project. Olena, the floor is yours. Thank you very much, Svetlana. Good morning, dear colleagues, those colleagues who are next to me offline, those who are abroad, and I have to congratulate
Dear participants of the National Conference, we resume our stream. Unfortunately, we had technical problems with internet access, but we thank you very much and hope that you continue watching the National Conference on Management of Drug-Resistant Forms of Tuberculosis in Ukraine. We celebrate and we congratulate the National Institute of Physiology and Pulmonology to its 100th anniversary, and out of 100 years, for 20 years, our organization, PATH, had been working with the National Institute. And now we are talking about partnership support within the framework of the project for supporting effort on fighting tuberculosis in Ukraine. Olena Dyuzhina is going to continue, and she will present her report on technical support. Thank you, our team, for resuming the stream, and I will start with the pilot geography. I will not talk in too much detail about it, but I would like to say that despite everything, we are going to continue our work, and we worked during the war. We only had a couple of weeks delay. Okay, we are back again with our online broadcasting. Dear participants of the National Conference on Management of Drug-Resistant TB in Ukraine. I would like to say that we have 266 participants joined us online. Thank you very much for that. So for the second time, we had technical problems with internet access. We had to make a break in our online broadcasting, but we are back. Thank you very much for your understanding and patience, because today we had UAV flying over Kiev, and we have some technical problems organizing all the technical aspects. Olena, over to you. Our way was not very easy. We had to organize serious advocacy campaigns. We had to cooperate with international partners. KNCV, special thanks for you for uninterrupted contact. Our national leaders supported us in everything. And we started our pilot project, of course, with developing the protocols, SOPs, and algorithms. We started with developing and introducing respective guidelines, so that we can ensure that the whole process from the beginning to the end is efficient. Of course, in order to be able to implement everything, we had to procure dispensables, we had to print all the templates for referring patients for testing. Then our laboratory specialists and clinical specialists were trained, and we try to keep in touch with them regardless anything. In November 2021, we started to implement our first tests of feces samples for TB diagnosis in regions. The first were Cherkasy region, Kirovograd region, and then others joined. And starting November 2021, all the pilot regions were covered, and this methodology was introduced at the regional level. And of course, all these developments and solutions that we received during the pilot stage of the project, we collected everything, generalized, and provided information to the National Anti-Tuberculosis Program so that other regions can use our experience as well. And of course, in all the regions that joined our project, there are 18 of them now, and we are ready to provide support for them in carrying out respective tests. We are willing and ready to cooperate and share our findings. We started before we had sufficient information. At that time, we only had emergency rapid communication from the WHO on using alternative feces samples testing for TB diagnosing, and thanks to that communication, with support from the PASS project and in cooperation with Yanovsky's Institute and our specialists from the Public Health Center, altogether we developed and published methodological guidelines which we were able to use starting 2020. And of course, for us to be able to implement it in practice, we needed support from laboratory and clinical specialists. In October 2021, we presented the protocol developed by our pilot project. And in November, as I said, the testing phase started in our regional laboratories. So what were the inclusion criteria for children that we used for our pilot project? So we worked with children under 5 years old, and then other children above 5 years old, children from whom it was difficult to receive the samples from the throat, because those samples are the golden standard. When it's possible to receive this throat sample, we use it as the first choice for laboratory testing. But when it's not possible, especially in young children under 5, it's very difficult to receive this type of tests from them. And for them, and then we also use this type of samples for children up to 15 years old, if it was not possible to receive sputum from them. So after consultations with our physiologists, we collected feces samples that were delivered to Laboratory of Oblast anti-tuberculosis facilities. We did not violate any national algorithms. We just added feces testing to normal routes of clinical protocols prescribed by the national guidelines. Of course, without support from our organization, anything would ever be possible. From our side, we had online discussions of clinical cases. Once a month, approximately, we had general meetings involving laboratory specialists and clinical practitioners. Then the war forced us to change our routine, but we had 7 online meetings involving all kinds of specialists from clinical sphere, from laboratories, and the specialists from our project. You can see a picture. I love pictures very much, so we can see our laboratory specialists and our professionals keeping contact from home, from the office, so for you to not to experience any issues. We organized field visits for the project specialists, then we organized training for special family doctors, and so on. And I'm pleased to present our results. Our specialists saw it, but I'm happy to share it with the rest of you. Since November 2021 to September 2022, we entered data, all the received data into our logs. So all data were entered into the system, and in the regions we tested 168 children, 84 girls and 84 boys, and only 6 results were invalid. So the reaction did not happen, and it was not possible for us to determine whether the result was positive or negative. Such things happen, and our laboratories demonstrated how well developed they are and how careful they were about testing these samples, and they followed all our recommendations and protocols. So only 3.6% of samples were invalid, and 18 were positive samples. This was also a good result. That means that with the help of feces testing, we were able to provide laboratory confirmation. Out of 168 tests, we were able to receive 18 diagnoses. So that's 11.1% of all samples that were tested. And if you can see, Gunta mentioned that. So we had more children aged under 1, and we had other children aged 9 and 10, and sometimes we had above 18 years old, as you can see here. So unfortunately, there are children for whom it's not possible to provide this Pufun sample. So we had elder children with some mental problems, and we also provided the possibility to have these tests for them as well. But the positive results, as you can see on the diagram, so these figures in the middle show the number of positive results, and the highest number of positive results were for children under 1 and for children under 9. So really this test and this research demonstrates that in the event when it's not possible to receive a sputum sample, then we should go for a feces test to receive laboratory confirmations of the TB diagnosis and to see whether it's resistant or not.
And I already mentioned, besides, to collect samples of feces, so children as a part of national protocol. So we also collected traditional samples. And you can see on this slide the percentage of collecting different types of samples. And you can see so that if it's like stomach sample, that's also pretty good result, as all international recommendations showed. But you understand that to collect a sample of species is quite easy. So for children, that's a very natural process to provide samples, even a few times a day. But to collect sample from the stomach, that's invasive procedure, and it's not pleasant for child or the parents. So of course, if there is a need to diagnose TB for children, we need to really think about which sample type you would like to choose, if sputum is not an option. And as a part of our pilot project, which diagnosis we get, so when we get like positive, so and you can see that we have infiltrative or disseminated TB and the first time diagnosed TB. And the first time when the child cannot give sputum, so they swallow this material. And so when they swallow this sputum, so then there is enough biological material in the feces for us to diagnose them. So since we started this testing, we work with 168 samples. I already showed you the age groups, so I will not go into details. So most of all, we worked with little kids, kids under 5. In 132 patients, so we collected other samples besides feces, but not all of them, only 132. 25 samples, that's 14.8% of other biological materials were positive. And out of them, 10, this is 6%, they were also positive of feces samples. We received only 6 unclear results, so 3.6, and 18 positive. That's 11.1. And if we look into these 18 positive samples, and if we try to understand what it gave us, we can see that out of 100 negative results of other materials that we collected, but we didn't receive a positive result, 6 out of them were positive. So what information it gives us? That we were able to prove the diagnosis of TB using this feces test. And 2 we got out of 36. And we couldn't collect any other type of samples. So we couldn't take a sample from stomach or sputum, and it shows that as a part of our pilot project, so 8 children could be diagnosed, and that was the only way that allowed us to do so. And if we look at it from different perspective, these 8 positive results, and we look into them, we can see that out of these 8 positive, which we could find only by feces test, so 5. So we have, and out of them, so we got the RIF plus, which means that we could diagnose TB, and we found that it was RIF-resistant TB. And I have to show you this very interesting case. So it was a boy, 6 months old, with a family with many children. So he didn't receive BCG vaccine because parents refused. So tuberculosis contact was with stepfather, who had tuberculosis in 2012, and he was cured. But in May 2022, there was a relapse, and he was diagnosed with pre-XDR TB. So all members of the family, they were tested, and you can see that only this tiny boy had some changes in the lungs. So there were no complaints or any symptoms. The boy was in good condition, taken care of, no deficit of and based on the national protocol, the child was tested. So we had the analysis of stomach, and then we tested the feces, and we received, you can see the photos. You can see that the right lobe is extended, and the left toe is not changed. And when we use GenExpert, MBT was found, but it was not found that it was REF resistant, but then when we had feces test, then we found out that it was REF resistant. And based on the recommendation, so we used the expert XDR, and we could use this very important information, uses feces test, and we were able to do it very fast. And we could find the resistance to the drugs of the first and second line. So the child was diagnosed with pre-XDR TB, and treatment was assigned. So the algorithm, based on recommendations of WHO and based on the experience of our pilot, now we offer this algorithm. If there is possibility the child might have TB. And if it's impossible to take a sputum sample, because that's the sample that we aim at, then we can choose which sample we are going to choose. It can be, you can see all the options that you can choose, and feces is one of the options. We can really think and choose the best option which will be suitable for this particular child. And also we need to choose that sample which will give us the most information. And I would like to draw your attention that is a part of the pilot. And now we offer that when we receive Ref Plus, so we recommend Gen Expert XDR so to find out about whether this resistant form. And of course, I have to say, I know that we have limited time, but I have to talk about this once again. That's sputum, spontaneous or induced. That's the best material for a bacteriological test for TB. But if it is impossible to receive this sample, that we need to think which sample we can use to diagnose in laboratory way TB. And of course, also the result of this test depends on the type of TB, because if there is nothing in the lungs, then we don't get anything in the feces, because everything that the child swallows back, that's what we can get. But if the child doesn't have, so if there is nothing in the lung, then we don't get anything in the feces. And we recommend Gen Expert MTB Reef and Ultra, and it shows the same accuracy, but the advantage of it is that it's not invasive sample, and of course the further decision of the doctor is based on all the testing and all the observation information, and we need to make the decision all together. Thank you very much. Finally, I was able to finish my presentation. Thank you very much, Ms. Olena. Yes, it was not easy for Olena to present, so we lost our stream twice during her presentation. And implementation of this innovative ways of testing for practice to diagnose children TB for children now, that's what we heard about, and I want to thank you. And I want to thank all the team that worked with us at the Center of Public Health, the Institute, and of course our regional specialists, both doctors and lab specialists, always stay in touch with us. And we keep going, and you can see that in this National TB Hub, we have one more person. It's my colleague, Volodymyr Shukatka, who joined PAS quite recently in June of 2022. Mr. Volodymyr is a physiologist, and he has more than 10 years of experience in fighting and controlling TB.
So he is the person knowledgeable about programmatic and clinical management of TB patients, including patients with resistant forms of TB. And now we are going to continue talking about diagnosing TB, and Volodymyr is going to make his presentation about introducing quantiferon test for diagnosing TB infection. And this test was implemented within the framework of our project. Thank you. Thank you, Svetlana, for warm greetings. I would like to greet all the colleagues who joined our conference, and we are grateful to you for all the effort that you implement despite of these difficult times and the time that you found to learn about all the innovations in this sphere. I would also like to congratulate the National Institute of Physiology and Pulmonology to their anniversary, 100 years of existence, and I would like to wish them to continue to be the leaders in the anti-tuberculosis sphere in Ukraine. I would like to demonstrate our to share with you the challenges that we faced in this process and the achievements, the solutions we developed for blood testing for TB diagnosis. As we know, and according to the international approaches, the most efficient and successful mechanism for treating TB and decreasing the TB burden is prevention. And here we have to pay special attention to people infected with TB. We have to detect them in time and to start treatment, preventing further development of the disease. WHO in September 2022, WHO published updated module 3 for diagnostics. We are talking about information about the tests recommended for TB diagnostics. There are 3 types of tests, such as skin sample, a gamma interferon test, and TB blood test. So when we expanded our access. Now we have only 2 types of these tests, such as widely used skin test and gamma interferon test that was used more sporadically, and there was no regular practice of its implementation. Our project specialists decided to stand up to this challenge and implement a project expanding access to TB diagnostics using QuantiFERON TB test. Special attention was paid to children who contacted TB-infected patients. So starting September 2021, we provided free of charge access in all 12 pilot regions of the project. So we provided this free of charge access in commercial laboratories, and that achievement was preceded by very careful and painstaking work on market study, on developing laboratory services, and we also analyzed the laboratory network so that this possibility to get tested could be brought closer to the patient, and so that the patients have no obstacles getting to the laboratory to provide their blood sample. We did not have any previous experience of systematic application of this approach, and our project specialists analyzed the data from all pilot regions in order to understand which number would be necessary for each individual region. Within the framework of the project, we developed the pilot protocol, and we included the algorithms for selection and examination of patients for this type of tests. Then we developed SOPs aimed at improving and optimizing the work of laboratories. And the milestone in the initial stage for us was an offline meeting because the COVID restrictions were lifted. And in 2021, we had a working meeting in Kiev, at which we discussed the issues related to organization of tests and preventive treatment. The meeting was attended by representatives from all pilot regions and specialists who were and are responsible for organizing testing at the local level. During this meeting, we presented the pilot concept implementation paper, and we discussed the basic tools for the specialists responsible for organization of testing. So we presented this overview for the meeting participants on how to use electronic cabinets used for the laboratories. During the entire pilot stage, we introduced and implemented the system of regular training and supervision for specialists from the pilot regions. And during the implementation period, we conducted 10 online meetings to discuss the status of the pilot implementation, to demonstrate interim results, as well as discussion of challenges and possible ways to overcome them. It was rather relevant that we organized series of meetings in each individual regions, during which we discussed clinical cases. These meetings were held in all pilot regions, and more than 10 clinical cases were discussed. And from the project, we provided clinical and laboratory specialists. And from the side of the region, all people and doctors attended these meetings. These were people who were involved in examination of contact individuals and development of the treatment schemes. We provided recommendations concerning expansion on the range of tests necessary to exclude active phase of TB, which is necessary for efficient treatment. We discussed the issues and schemes of preventive treatment, selection of the regimen, and we also considered the possibility to involve NGOs in social support, in providing social support to the patients in order to decrease the alienation of these patients. And then we also worked with patients, parents of the children, telling them about the need to get their child examined and continue preventive treatment. Because of the full range hostilities from our neighbors, the beginning of this full-scale war in the territory of Ukraine, because of those developments, we had a break from the end of February to the end of March. But already in late March, we started working in the relatively safe regions, and we resumed our activities in 7 regions: Dnipropetrovsk, Cherkassk, Poltava, Odessa, Lviv, Kiev, and Kirovograd regions. In Chernigiv region, we provided access to testing in August 2022. In response to the war realities, we expanded the project geography, and in September we were already able to refer patients for testing in 4 other regions: Rivne, Zakarpatska, Chernivtsi, and Vinnytsia regions. Unfortunately, as of today, we still do not provide access to testing in Mykolaiv, Kherson, Donetsk, and Zaporizhia regions because they are partly occupied and the hostilities are too close. On this diagram, you can see the application of tests. And I would like to mention specifically that during the first months of the pilot, we organized a lot of training sessions, and we created risk groups, and we practiced the algorithms. And as you can see, after this forced break, when we started resuming our work related to examination of the key populations, then after that we were able to reach the pre-war level, and then we exceeded it, even despite the fact that we were not able to provide access in some regions. I would like to demonstrate some results over the 1 year of implementation. So 3,240 people were referred to testing. So these are people for whom the need for TB test was identified. 85 of them were tested. We received almost 20% of positive results. So every 5th person who was tested was diagnosed with TB infection, and 73%, 388 individuals, started preventive treatment. Since the priority group for us were children, they accounted for the largest share of individuals who were tested. Children aged 5 to 14 accounted for 51% of all tested individuals, and we also involved younger children, so 428 children, adolescents approximately 9%. But in the regions, we had a possibility, if necessary, to test other categories of individuals, such as IDPs, for which presented a very important challenge after the beginning of hostilities. Then we also provided tests for adults who were in contact with infected people and social workers who contacted infected individuals. Special attention was paid to determining the resistance status of the patients, because the test result does not demonstrate the level of resistance and does not enable us to identify the treatment regimen. As you can see, out of the entire number of people referred for testing, 80% were with sensitive tuberculosis, and the rest were people who were in contact with drug-resistant TB. Out of them, 80% were tested positive, those who contacted sensitive forms of TB, and 22 positive results were received for those who were in contact with sensitive and resistant tuberculosis. Then we had a lower level of people from the center of resistant tuberculosis. And the main reason for this is that fluoroquinolone-resistant forms of TB was diagnosed with the index patients, and in this case, you cannot determine the treatment regimen. But our task was not only to expand access to testing, but to ensure efficiency of preventive treatment. And we carried out advocacy campaigns for implementing short-term preventive treatment regimen for people who were in contact with drug-sensitive TB. As you can see, during the fourth quarter of 2021, which was the first quarter of work for our project, we had the share of short-term and 6 months regimens. The shares were almost the same, but we worked with a specialist, we provided contact support, assistance and supervision, and that enabled us to increase the share of short-term treatment regimens, and because their efficiency was demonstrated and proven, and this preventive course is now shorter than a standard course. I would also like to share the results of preventive treatment with you for individuals who were tested.
So in the fourth quarter of 2021 and first quarter of 2022, 430 patients started preventive treatment, and so basically 75% they finished successfully this course. A lot for follow-up, that's 10% of all of them. Unfortunately, here we have, this is the consequences of military hostilities, because we cannot estimate the results for 52 people, which is really unfortunate. Also, the failure was for 14 people, that's 3%. And also we registered a side effect for one of the TB drug. That's why this treatment was stopped. And here I would like to say that after in-depth analysis of people who stopped treatment, we figured out that they received 6 months treatment with lisinopril, and at least half of them, and maybe we could have prevented that if they were assigned this preventive treatment. So what is the situation with quantiferon testing for December 2022? So we used 80% of tests which were planned, and you can see on the graph the percentage of how the tests were used in pilot regions, and the quota of tests which were allocated for people in these regions. And also I have mentioned quite a few times that the main barriers these were the military hostilities, partial occupation of territories, also internal migration population, not only moving to the west of the country, but many people had to leave the country completely. That is why we didn't use all the tests, but cooperation with commercial labs, it gave its advantages because the procurement of services was organized for all regions. And we managed to respond promptly to issues like using the full quota in certain regions, and also organizing the access to new projects in regions. So we didn't have additional procurement. We just reallocated the tasks where they were necessary. And as a part of our implementation, so we came to these conclusions that quantiferon testing requires a sustainable approach, so with constant approach, constant access, and also we need to train the personnel so that they select people properly for this test. And as I said, that every fifth person who went through testing, they had tuberculosis infection, which proves once again the necessity of the program to test and diagnose. And also introducing the shorter preventive treatment regimens, and because it increases the effectiveness of preventive work. Also, cooperation with private labs, it guarantees the stability of work, and also the best treatment is based not only on the result of the test, but also diagnosing correct type of resistance of TB. Thank you very much. Thank you very much, Volodymyr, for this really detailed presentation about quantiferon test when we diagnose TB infection and in preventive treatment. Thank you very much, Volodymyr. And our session devoted to our cooperation with is still going on. We are a bit behind with time, so sorry for that, but we already had technical issues twice, so it's out of our control. So I'm giving the floor to Ms. Olena Pavlenko, who is also the manager of STBCU, and she works in PATH. I would like to say that Ms. Olena has 15-year experience, expert experience working with TB and HIV co-infection. Olena worked on the national, international levels on TB, HIV co-infections. She has 10 years of experience of international and national organizations on controlling TB, HIV co-infections. So can we please show the presentation from STBCU and give the floor to Ms. Olena Pavlenko? And it is about of testing for TB in high-risk group using mobile X-ray equipment. Let's listen to this experience. Dear colleagues, thank you very much for the possibility to introduce our experience about increasing finding the cases of TB using mobile X-ray equipment as a part of STBCU project, which is implemented by international organization PATH. Because of the pandemic and quarantine measures and the limited access of population to healthcare services, including TB, in 2020, 2021, in comparison to 2018, 2019 of the same period. So the finding the cases of TB decreased almost by 30%. So we needed to find the new ways how we could find those cases. And so we had the experience of mass screening, but it was not cost effective, and we needed to find best approach which would be more effective and efficient. We needed a few stages. Of course, political will was important, and of course to have necessary people and to coordinated work with partners. And of course, we needed the technical equipment, having mobile X-ray equipment or modernizing this equipment. Also, we needed to form the schedules, the number of tasks, and also we need to develop algorithm and models of diagnostics with engaging all partners. So the first region for the pilot was Chernihiv region. In Chernihiv region, there was a quite high level of political will, and the patients were in pretty bad condition and serious case, and they needed to be hospitalized. Also, they had a difficult social profile. Majority of these patients, they didn't have declaration of family doctors. So how we prepared for this work? We presented it at the meeting of Coordination Council on combating TB and HIV and infections in the Chernihiv Regional Administration. Also, we sent the letters of request to the heads of the healthcare centers to form the risk groups. Also, we had working groups with partners. We organized these meetings in amalgamated communities in the region, including the heads of amalgamated communities and also primary care facilities. Also, we engaged region-level physiologists. Also, we visited the monitoring visited primary care centers before and during the project. Which challenges we faced? First of all, it was a big event in the village, as professionals mentioned in Chernihiv region, because when this mobile X-ray came, so not only risk groups came to be tested, but everyone came if they wanted to test their lungs. Secondly, it took a lot of time for some extra testing if there was allegation of TB. So that was expensive to travel, so it was far for TB facility. It was unusual route. People have habit of going to the rayon level hospitals, and this was the reason why we lost some of the patients. In order to engage risk groups to organize screening for TB, we need to have cooperation with all partners and stakeholders. Of course, TB services, they have the leading role, and this new approach included the work with heads of amalgamated communities or territorial communities, with also with administrative support and also increasing awareness of the population. Of course, we needed to develop algorithms and models of complex diagnostics during screening and the follow-up of the patients. Of course, the role of NGOs is very important as well, because with their support, we can support patients at the pre-screening stages or during the treatment. So the screening strategies, they optimized all the time to actually target the correct group of population. So algorithms were approved on the national level. So these algorithms, they are completely in line with recommendations of WHO. As a part of this pilot project on supporting mobile X-rays, so we use algorithm and models of a comprehensive approach of expanding healthcare services. So these approaches are optimized all the time if there is possibility. So high-risk groups, they have a chance to have screenings for TB. They can do X-ray diagnostics. Also, they can have of pre-test consultation and HIV testing, COVID test, of test for Hep C and P, and also if there is necessity, we can collect sputum to use a gen expert for this test. So what results we received in Chernihiv region over the second part? In the second half of 2021, we visited 66 territories and we worked with 7,113 people. 140 people, they were sent for further testing. These were people with possibility of having TB. 126, they had additional testing. And 72 patients started treatment. If we look into on the third quarter of 2021, when we test all population risk groups and not, so we needed to work with 121 people to find one patient. If we look in the fourth quarter,
if we look into the fourth quarter, when we see when this activity was already targeting the risk groups, we can see that in order to identify, to detect one TB patient, we had to examine 67 persons belonging to the risk groups. So we optimized the approaches, focused on hard-to-reach risk groups at the primary level, brought these positive results. So we developed the algorithms and models of comprehensive diagnosis of TB and further examination of people with suspected TB infection. If we look at this slide, then as a result of carrying out X-ray examination of risk groups, approximately 20% of patients were identified over the entire period. I emphasize it was X-ray examination, and 90% of these people were undergoing outpatient treatment, and only 10 had to receive inpatient treatment. As to the support we provided to anti-TB facilities in the pilot regions, we bought 4 ultramobile X-ray devices and 1 X-ray mobile in Kirovograd region. We modernized 3 X-ray vehicles in Poltava, Dnipropetrovsk, and Kyiv region this week, and 1 X-ray vehicle is being modernized in Mykolaiv region. Also, with the help of the technical support from our project, we introduced X-ray information system in Lviv region. Then we are working with several regions already in this year, providing X-ray screening support. At present, we provide X-ray support for X-ray screening in Poltava and Odessa regions, and we are planning to include Kirovograd, Kyiv, Chernihiv, Cherkasy, Mykolaiv, and Zakarpattia regions. We worked in Chernihiv region before the war. Unfortunately, the X-ray vehicle was damaged during the military operation, and we did everything to we did everything possible to enable resuming X-ray screening in Chernigiv Oblast as well. So the conclusion is that thanks to the comprehensive approach to active detection of TB among high-risk groups using mobile X-ray equipment, we were able to identify 19% of TB-infected people as a result of X-ray examination. This healthcare service is brought close to the patient, and it enables us to diagnose TB at an early stage at the local level, and in the majority of cases, the inpatient treatment is not necessary from the very first day of detection of a TB patient. Thank you very much, and I am ready to answer questions if there are any. Thank you, Dr. Elena, and we in our PATH organization would like to thank everyone who joined our stream, who leave their comments in the chat box. Now we have almost 300 participants online, 293. So we received a lot of thanks to the specialists of the project. We have 5 minutes only. Now we can have this rapid session for questions and answers because we had some delays because of these technical problems. We know that the project director, Gunta Dravnitz, is with us online today, and we have a question or several questions, not only comments, in the chat on the National TB Hub of our YouTube channel. So not only comments, but questions were asked by the participants to Olena Dyuzheva, who was talking about diagnosing TB in children. So Miroslava Sergeyevna left a comment. Thank you, Olena, for this interesting work on testing children. Which protocol is used to regulate the procedure, and was it recommended by the WHO? Yes, we have recommendations from the WHO. It's Module 5, revised and announced in March 2022, and in the draft national standard on TB already has a respective provision. So we're still waiting till this national standard is signed, and we hope that this will happen very soon. Thank you for your question. Thank you, Olena. And a clarifying question from myself as a moderator. So for children, which age is recommended for referral to a feces test if there is suspicion of a TB infection? Thank you for your question. It is really important, and according to the WHO, these are children under 5, but if we have problems with receiving sputum, then older children are also included into this cohort. So there is no age limit. So the only criteria is problems with receiving sputum samples. From our experience, we can say that these are children up to 15 years old. But if we don't have the possibility to collect the sputum sample from elder children for various reasons, because they have accompanying pathologies, mental disorders, so such sample can be taken from elder children as well. So I'm talking about mycobacteria of tuberculosis. So this test can be carried out for older children as well. So up to 5 years old, this is the target group for feces testing, and above 5 years old are also included if it's not possible to take a sputum sample from them. Thank you, Olena, for this explanation concerning the age group. We also have a question for Volodymyr. You presented our project activities in the sphere of carrying out quantiferon test to diagnose TB infection. This project supporting effort in combating tuberculosis. Is the project planning to continue to support this blood test for TB diagnosing? Thank you for your question, Olena. The project continues and will continue to provide support in this area. We are thinking about procuring additional tests, quantiferon tests, so that the regions can continue doing what they're doing. And I hope that in those regions where we have no possibility to provide access to this test because of the difficult situation. But if the situation improves in the nearest future, we're going to cover these regions as well. And I would also like to thank specialists in the regions for their hard work, and for their being real specialists and professionals, because all the results that we received became possible due to their work. Thank you, Volodymyr. And I can see that Gunta Dramnitse, our project director, is also with us. If you have any questions, Gunta, maybe any comments to close our session? We are finishing, but we still have 2 minutes. So over to you.
Svetlana, and many thanks to my brave colleagues who continued to conduct the session. Despite the challenges, we are learning from situation, and you will be more flexible in other sessions. So, yeah, many thanks, and all the support which a colleague showed, we will continue also in 2023. So, for colleagues from regions, we are there. We are not the organization to whom you can provide a shopping list and ask what do you need. We have our own strategy, which was agreed with Ministry of Health, with National Tuberculosis Program. But of course, we are discussing with each region what are the additional needs, and we are happy if we can provide support. So you know your coordinator from our side. Please contact coordinator of Oblast, and we will see what else we can support. Thank you very much.
Yeah. Thank you, Gunta. Our project continues, and in the end, we would like to congratulate the National Institute on behalf of our organization with its 100th anniversary, because it's the leading institute working in the sphere of physiology and pulmonology, and it is also a reliable partner in all projects that we've been implemented for the last 19 years in the sphere of TB control. Thank you, everyone. Thank you so much for your attention, questions, patience, and glory to the armed forces of Ukraine. Now we will have up to 10 minutes break, and then we will start with our next session on microbiological diagnostics of tuberculosis. Thank you.
Dear colleagues, good afternoon. We are happy to welcome you at our conference, which allows us to celebrate the 100th anniversary of the National Institute of Physiology and Pulmonology. And I'm happy to start our microbiological section, and I welcome all my colleagues, everybody who is present here, or those who just joined us in any format. And as our conference is devoted to 100 years of our institute, I would like to say a few words about the Laboratory of Microbiology in its historical context. I'm very happy to say that 100 years of our institute is closely connected with the development of microbiological methods of TB diagnostics. And today I want to mention different heads of the lab of our institute. That's Professor Drapkina, the member of Chernyshenko Katarina, Dr. Ginsburg. And scientific research of the laboratory, they always were connected with the improving of lab diagnostic method of TB. So we studied in vitro drugs of torhinolones. We also were learning about the effectiveness of different regimens by studying of blood indicators and also of the types of mycobacteria used in animal testing, and the history of Kyiv Institute of Tuberculosis is connected with leadership role of the lab, where professionals on lab diagnostics started, and these professionals were coming from all over the former Soviet Union here. And this lab was used for further professional development and training of different nationalities, different countries of the former Soviet Union. And I'm very proud and happy that we continue these traditions here in our lab. We keep training our colleagues, bacteriologists. We continue those traditions which were established by our great teachers, our founders, and I'm very happy that we keep doing scientific research which is extremely relevant for modern microbiology of tuberculosis. We work in a modern laboratory in safe conditions, and with support of administration of our institute and the National Medical Academy and our partners, we can keep working, improving not only our knowledge, but the knowledge of our professionals on lab diagnostics, on physiology hospital, and we're always happy to support our patients. So we keep our traditions going, we keep working, and now we are starting our session on microbiology. We are going to discuss the modern stage of development of our microbiological diagnostics of TB, modern approaches, new methods, really innovative technologies which are going to be implemented in microbiological diagnostics of TB, and it will become the routine diagnostics. And today we'll discuss the ways and directions of our national methodology, and we will talk about important aspects of lab diagnostics as diagnostic assistance of the people in penitentiary system, and also assisting children, which has already been mentioned before.
So we've discussed it before, and today we are going to talk in more detail about microbiological aspects of TB diagnosing in children. And furthermore, we are going to discuss modern challenges as well as risks that we identify and analyze on the way to further development of lab diagnostics. So traditions continue, and we start with the presentations of this session. My first presentation is about microbiological diagnosis of TB, modern and contemporary challenges. It was prepared by me and the head of our lab for microbiology and biochemistry, Alexander Zhurilo. Dear colleagues, tuberculosis is infectious disease, and regardless of how many years we work on it, I will repeat it again and again, because the agent causing this disease has to be identified or detected depending on the methods of diagnostics. Lab diagnostics of TB uses a lot of methods. Laboratory technologies depend on the tasks and objectives posed before us by clinical specialists. So we can identify the response of the microorganism to identify the agent. Then we can describe characteristics of disorders and functioning of various organs and systems. Then we can provide characteristics of tissue changes such as morphological verification. And in red, we have number 4 is identification of the infection agents, including methods of etiological diagnostics, which is very specific types of diagnostics that covers molecular genetic technologies, cultural methods such as fluid and hard spheres, and a microscopic analysis. Regardless of the methods of diagnosis we use, the basic principles of TB diagnostics according to WHO recommendations, and you can see that these recommendations and guidelines were consolidated and issued, published in 2022, and then updated in issued in 2020 and updated in 2021. So the methods should correspond to the highest level of evidence for the respective process. We have to use only validated lab technologies with known and proven characteristics. If we use the methods with a low evidence class, then we will need to provide additional quantitative support for the methods that are used for TB diagnosing, and to exclude false or error in diagnosis. So the materials should be as close to the pathological process as possible, and these are the approaches we use in our everyday practice. In the consolidated guidelines of the WHO for rapid TB diagnosing, covers a wide range of methods, and the primary first choice method is molecular genetic methods and techniques, which are the primary tests used to identify the resistance status of the agent. We use expert MTB REEF or expert MTB REEF Ultra. This is used in Ukraine. Then we have further diagnostic tests for identifying drug resistance level. That was expert MTB XDR test that was implemented in Ukraine in 2021. And LPA is a primary test for identification of resistance to medications of the first and the second group in the case of positive bacterioscopic results. This test is used only with limitations in Ukraine because it's not possible for us now to procure materials used for the test related to the problems faced by the producers. Then we also have phenotypical methods which are used to carry out sowing or planting methods to identify the culture and to monitor the treatment results. And we also have microscopic analysis, which is not the primary test. It's not used at the primary level, but only at the regional level in bacteriological labs that provide the entire range of tests for TB identification. Dear colleagues, I enumerated a whole range of methods now, and we have to use them for various purposes. We use them to provide our clinicists with the complete information about the agent causing TB. It's very important for clinical specialists for choosing the treatment regimen. You know that we can provide this type of data and information when mycobacteria can be resistant to rifampicin or can be sensitive to rifampicin. It's important for choosing short-term treatment regimen, or we also have to respond very quickly when we are talking about resistance to fluoroquinolones and for the second line drugs. Also, when we identify individual regimens, we need to know the level of resistance to fluoroquinolones and to the second line drugs. And this information is respected from the labs, and we have to carry out research with the maximum efficiency and accuracy. So in view of all this that I said, we have the following algorithms consisting of several steps. The first step would be identification of mycobacteria and reef resistance. We have to carry out rapid molecular analysis at the entrance point of the patients to the healthcare system. We have 132 expert MTB devices at the primary level to identify tuberculosis and reef resistance. The second stage is that all bacteriologically confirmed cases require rapid analysis for identifying the risks or resistance to fluoroquinolones or the second-line drugs. And we use this rapid system called Expert MTB XDR. And the third step, all cases of rifampicin-resistant TB or MTB require a quick test to identify resistance to the second-line drugs so that our clinicists would be able to adjust the treatment regimen based on the test results identifying resistance to the second-line drugs. Okay, colleagues, I now would like to say that despite the fact that we implement all methods of diagnostics, but the challenges for us is to ensure high quality and prompt testing and implementation of new techniques in our testing practice, such as molecular genetic methodologies, sequestration and target, and full gene sequencing. So in view of this, I would like to mention that one of the relevant and most pressing issues in Ukraine, in its modern healthcare system in Ukraine and worldwide, the problem is tuberculosis in children. And it's a really important indicator reflecting the overall situation with TB in the world. We have to address such issues as early detection, identification of resistant forms of TB in children. All these are very important activity areas for all specialists involved in addressing this problem. And I already mentioned it, and Olena yesterday mentioned the problems with children TB, that it's very often non-diagnosed in 64% of cases compared to the situation with adults, and every year 1.1 million children worldwide suffer from TB, and only a small share of them is registered at the age from 0 to 4 years old. So TB in children is a huge problem. And when we are talking about microbiological features and characteristics of TB in children, we have such challenges as oligobacillar character of TB in children, because they emit only small part of material, and the content in this material is very low, and it's very difficult to receive respiratory samples. Then there is a need to carry out invasive procedures in children, which is also very problematic. And I would also like to mention that children under 5, it's for these children, they are only tested after a contact with this source of infection, but it's not always possible to establish whether such contact has taken place. So children usually receive treatment on the basis of clinical features and other non-specific manifestations. We have international guidelines and other international documents published in 2019, 2021, and we have 2022 guidelines, and we implement them in practice in our everyday work in microbiological labs for TB diagnosing, and we carried out huge preparatory work for that, because we drafted an order that was approved by the Ministry of Health and the Ministry of Justice on approval of the guidelines for microbiological diagnosing of TB. It was done even before the respective guidelines were approved in the rest of the world, and we already had approved feces samples that can be used as alternative samples for diagnosing lung TB in children. We also have recommendations or guidelines that were approved by the Ministry of Health and approved by the Research Council of our institute with support of the PATH. So we have guidelines on using alternative samples for TB diagnosing in children and in adults. So we laid the foundation for implementation of international documents already in 2019.
And Olena already presented the clinical aspect of diagnosis of TB for children. for physics test, but I would like to comment and to talk about microbiological aspect because it is very important. And I would like to say that when we only used the microscopy and when we used like the previous methods and then we started to use BACTEC in 2006, and there's darkness of pathological diagnostics of confirming the cases of TB increased by 26%. For us, it was very, very good result. And that is why I would like to say that when we started to implement molecular gene test, so when we started to use XR cartridges, Ultra, so then for us that was a very good result, and we also could check that even if 11.1% the percentage goes up and confirmation goes up for children, that is a very good result. On this slide, I showed regions which were part of the PASS project. These are 12 regions which participated for physics test, and 11.1, that is the effectiveness of this pilot, and it is a very good result. And also I would like to show that the leaders, when they were selecting these children, these were Dnipropetrovsk and Odessa regions, and they had like really thorough task because physics is very specific material, and it can have like all different other bacteria. So that was a really hard work of our lab together with clinicists. And also I would like to say that if we talk about bacteriological point of view, when we analyzed 18 positive results of in GEMTAS, so we had like that 50% of the samples, they had the DNA of mycobacteria, and then other 50 they had also DNA of other mycobacteria. And if we find traces, so if as a result of this test, then we cannot define the resistance to RIF, and so this way we could not find out the resistance to rifampicin. So this could be sensitive or resistant forms, but samples did not prove this, because usually it is not possible to do so, or in very rare cases, but that is a risk, because half of the children we still don't know which level of resistance to rifampicin is there. And you can see that all other 50%, they had a different level, low level, and rifampicin also was not defined. And you can see all the percentages on the graph. You can see that we have the low level and middle level, and also the biggest number with middle level with mycobacteria. Also, they were RIF resistant, and I have to say that these are children from 0 to 5 years old. That is why 16.6%, that is a very high result, and that is why it is a pretty high level of threat for children population. And also, Olena has already mentioned that other samples were tested from children, other types of samples, at the beginning of the pilot, in the middle of the title, because it was basically OR. And in practice, it happens a bit differently, because if you either in feces or in other samples already find mycobacteria of TB and define the level of resistance to rifampicin, you don't need to test a few samples. So it's enough to have one informative sample. And I have to say why we tested other samples, because for children with symptoms of pulmonary TB, sputum is the most valuable sample. Aspirate of stomach, yes. So usually the test is lower for children under 4, but if it's not possible to collect sputum, then it can be informative material. You can see that basically feces, that's the most benign sample, if you can say that, but we can say that the highest level of accuracy, that's for sputum. All other samples based on WHO recommendations, so their accuracy is quite low. And if we talk about children with extrapulmonary TB, we had so these children are not very informative if we use this method. And I can say that in our test, the most informative, these were about their stomach sample, which we checked together with feces, and the least informative, as I say, that about extrapulmonary types of TB. And you can say that if it was like stomach sample, that was 12%. And general informatives, that's 18.8%. So then the sample from nose and throat, that was 4.5, and sputum, that's 1.5. So we just couldn't get this sample from these patients. And this slide is very interesting because so like how informative this feces can be in comparison to other materials and other types of material, but I can say that general level of information, so it's a 7.7% of positive result, only feces. They were positive in 4% of cases. Other alternative samples without feces, they were informative in 11.5%, and negative were 76.2% out of all tested samples. That is why I would like to repeat that if it is possible to test feces, so that's, we are going to do that. If children are of older age group and it's possible to test sputum or the nose and throat culture, then it's more informative. What challenges, general challenges, when we have lab diagnostics of TB? Quality and speed, that's what's important. And here I would like to show you this picture of the cycle of the high-quality diagnostic work. I can say that the work of a lab, it shows the work of all physiology area, because we have pre-analytic work, because how you need to collect samples. And here we're not talking only about feces, but about any diagnostic material for all types of methods of diagnosis of TB. That's why pre-analytic stage is very important because we need a targeted selection of patient, prepare the patient for collecting samples, and the process of collecting sample is very important as well. So to receive the samples, marking them, transporting, and only after that, that's where labs come in, because a lab cannot participate in pre-analytic stage. So about planning and doing the test and the control and quality control during testing, that's a competence. So the testing, that's what's happening in the lab, not the previous steps, and that's what we are trying to do. We are trying to do our work as quickly as possible, but we know our gaps. We work on it. But this pre-analytic part is extremely important, but this is responsibility of clinicist. So registry of the result, we have indicators. We know like how fast we need to give the result of the test to select treatment for the patient. And there are cases when we don't have electricity or some other challenges, but it's not systematic. It's just some extraordinary situation. And then we have post-analytic stage where doctors make their decisions about selecting treatment. And we know really well that we work for patients, for helping doctors, and for to help all of them to be healthy. And I would like to add that it's very important to do thorough work on every stage so that we can avoid possible errors. And in this cycle of quality, I didn't say about the quality control that all labs do, and now we send our control samples to a supranational lab of Germany in Germany, and so I'm very happy that our regional labs they are very successful and they managed to use this opportunity, because we are integrated in this system in European regional. So we are integrated the system of WHO of European region, and they help us with this control. And this is my last slide. So, and I would like to say, so even if we have some gaps, even if we have challenges, even if we have this situation here, which is not easy, now we are trying to provide fast, high-quality lab diagnostics, and I think that we will be successful. Thank you for your attention.
And now I would like to give floor to my colleague, Natalia Campos-Rodriguez, a laboratory specialist of the Center of Public Health, for her presentation on progress in lab diagnostics of TB, success indicators, and major tasks. You're welcome. Contemporary healthcare is not possible without lab diagnostics, without lab testing. It's very difficult to make or to identify the diagnosis. And proper diagnosis is the main precondition for high quality results of work of a clinicist. Laboratories do not treat or cure patients, but diagnostic information helps a clinicist and a patient to identify the treatment scheme, to assess treatment efficiency, and help them prevent severe course of disease in the event of early diagnostics. In Ukraine, we have algorithms for the diagnostic process. This algorithm envisages that the primary diagnostic test for TB identification uses molecular genetic mass. And Ukraine goes away from the microscopic methods being a least efficient method. Lab service in Ukraine has major tasks posed to it. We expand access to diagnostics methods. We ensure testing resistance to all drugs used for patient treatment, and we also have to provide high-quality services in our labs. On this slide, you can see that Ukraine has a wide lab network, and in order to implement the tasks identified in the National Strategy for Development of Anti-Tuberculosis Service, we are implementing the process of the optimization of the lab network, addressing the second-level labs. So second-level labs previously were involved in further testing of samples of non-nutritious environment. In 2020, we had 24 laboratories, and by the end of 22, we're going to optimize 4 laboratories. We also have new tasks for the first-level laboratories. As of today, we have 603 laboratories formally existing in Ukraine that carry out molecular tests and microscopic tests. So the major objective for the upcoming year for us is to optimize and to regulate activities of the first-level labs in accordance with the molecular and genetic tests that they are supposed to perform. As a result of the Russian aggression in Ukraine, 3 regional labs were destroyed in Ukraine, in Chernihiv, Donetsk, and Luhansk regions. And we also have laboratories that are now in the occupied territories, and we have no contacts with them. Because of this active phase of war, labs in Zaporizhia and Kherson, Luhansk, Zaporizhia, and Donetsk regions stopped functioning. As I said, when I was talking about the main tasks, I was talking about expanding access to early diagnostics, because in order to prevent the spread of TB, we have to ensure a rapid identification, a rapid resistance test, and prompt identification of the treatment regimen, and that all has to be done very quickly. And to this end, we have the network of labs and with gene expert systems. So you can see that these systems are installed in labs, penitentiary institutions, and academies, and other agencies and ministries. You can see on this slide the very high share of application of genetic molecular methods in registered instances of TB. In 2022, this share is 97, but these are 97% of those covered by molecular genetic methods at various stages of diagnostics. So we are talking about instances identified at the primary level, and then the cases that reached the specialized level and were examined using the very specific research methods or testing methods. The number of newly registered and repeat cases subject to various tests This number accounts for 71%. WHO target is 100% to 2025. So for us, the task is to gradually ensure application of molecular genetic tests for all cases that were and will be registered by 2025, including first-time and repeat samples. We also have this gene expert system in laboratories, and these laboratories do not only carry out tests for TB, because during the COVID epidemic outbreak, the laboratories in various healthcare facilities also received cartridges for identification of COVID infection, for testing COVID, and they continue to use it for COVID diagnosis until today. We have laboratories at the primary level in the AIDS centers in penitentiary sector, and starting next week, they will start testing samples for hepatitis C and the identification of the virus load. For us to be able to provide high-quality lab services in Ukraine, transportation of biological materials was organized in Ukraine with support from our partners from the Global Fund grant with USAID support. We also know that in order to ensure efficacy of treatment, doctors have to know the resistance profile. And for us to check this resistance level, we have to single out Mycobacteria, and we have 68% for first cases and 83.5% for repeat cases, and the target identified by the WHO by 2025 is 90%, and we are working together with clinicians to achieve this target, because labs confirmation requires proper selection of patients, collection of high quality of samples, appropriate transportation conditions, and a sufficient amount of biological materials. So in Ukraine, bacteriological service together with clinicians started working on achieving this indicator. We introduced quality indicators. We introduced internal quality audit. And we hope that by the end of this year, we will increase this indicator already. As of today, Ukraine carries out drug resistance testing in each regional TB lab. A phenotypical method is used with the help of BACTEC analyzer. You can see the list of medications, resistance to which is checked simultaneously. And we also have genotypical methods on the GeneXpert platform, because our laboratories received a GeneXpert system with XDR cartridge, and in this year we began to implement these methods. Since 2020, Ukraine started testing in all regional laboratories concerning resistance to dolominet and bedaquiline. And on this diagram, you can see the range of coverage of testing to fluoroquinolone resistance and group A drugs. So in the end of 2021, the coverage was 97%. But during the first 6 months of 2022, you can see that the share of coverage decreased by 10%, and we understand very well why this happened, because in February and in March, cultures was received, but because of the difficult situation, the labs were not able to test these samples to cover the entire range of anti-TB drugs. We only studied samples using a GeneXpert system and XDR cartridges. So I would like to use this opportunity to thank all lab specialists for their hard work, for their difficult effort during these hard times. I would like to thank lab specialists who left the occupied territories and together with their belongings, they also packed microscopes. I would like to thank lab specialists who buried GeneXpert system in the hope that they would come back home and continue their work. Thank you very much for this. And the third block covers ensuring provision of high-quality lab services that includes external quality assessment, human resources development, and implementation of the quality management system. This is a new block for our country, and our partners help us a lot with it. This national laboratory of the WHO that is located in Germany, together with them, with supranational laboratory. So together with our partners, we are working in our regional labs to prepare them for the international accreditation to ISO 15189. We carried out primary assessment of the regional services and carried out external quality assessment. This year, despite the logistical problems, we were able to deliver an international panel to our country, and 4 laboratories that are getting ready for ISO assessment. They carried out external quality assessment, and we forwarded this information to the laboratory in Germany, and Anna says that everything is okay. So we are very grateful to all our regional laboratories for successful implementation of external quality assessment. It was an international panel, and it was extremely difficult because it included all anti-TB drugs, including betaquilin and dalomamide. And we still have some activities that we still cannot implement, but we hope that in the nearest future we will be able to meet with our partners again and launch our joint activities. On this slide, you can see the certificates that we received from the Central Reference Laboratory confirming external quality assessment results. External quality assessment covered not only reference laboratories, but also included our regional laboratories. So after successful completion of assessment by reference laboratories, this control panel was forwarded to our regional laboratories, and external quality assessment was implemented to ensure implementation of the Ministry of Health order. So this is the picture of our workshops with our lab specialists. We share our success stories and experience with them. We exchange information about the problems and ways to solve them. Here you can see delivery of the certificate to our regional laboratories.
Also, one of the element of high-quality lab services, that's implementation of IT systems. So today, labs work the informational system for GeneXpert, which is called GenAlert, which was implemented by technical assistance of PATH, and also we started to implement LIMS system in regional labs. And I would like to say that in Ukraine, main diagnostical methods are implemented, those methods which are recommended by WHO, and we need to only to hear more about one more. Our colleague will tell us about it later, but I want to draw your attention to these two photos on the slide where we have sequencing equipment, and I think that the lower photos, that's our future. And this future will depend on all of us, whether that's a distant future or very near future. And to conclude our main tasks, which are aimed at improving of lab diagnostics in Ukraine. So these are our tasks that we have. This is moving into using ultra cartridges, also optimizing lab network, which will take into account methods which are used in the labs, implementing innovative methods of diagnostics. This is the task that is ever present. As soon as innovative methods are recommended, Ukraine is always ready to implement, also expanding access of patients to HAP diagnostics, improving the checking the quality, external checking of quality of GenExpert. And I would like to say that there is no standard for GenExpert for external quality check, and that is why the work recently was started, to improve that. Also, the laboratory information system, also preparing 4 labs for international accreditation and preparing other labs. Capacity for personnel and implementing sequencing on national and regional level. And to finalize, I want to thank all our partners because their activity is aimed at improving and development of lab service in Ukraine. Thank you for your attention. Thank you, Natalia, for this really comprehensive presentation. And basically, you describe all sides of our lab network, our service, and our further steps, perspectives. Thank you very much for your presentation. And I only would like to add to what Natalia has said, that our lab, it is in this in these conditions, I think they became even more thorough and more responsible, and our regional labs, they do the same. And I would like to say that in these conditions, all labs, they did really well in penitentiary and civilian sectors, except one lab, when they were checked by this control panel. And so this panel they received in May, and they did really well. Now we're preparing certificates about successful achievements, successful result of this panel. So I want to congratulate everyone, and we wish them all the best. So I want to thank once again our colleagues in the regions. And now I would like to give the floor for a presentation on the consultant on the Global Fund on lab diagnostics of TB, and she will present an interesting topic and important, that's microbiological diagnostics of TB in penitentiary system during military hostilities in the country, because organizing the lab diagnostics of TB for inmates, that is a very important topic, important direction, this very particular conditions, and I'm very happy that Ms. Maria is with us now, and she can present for us. So the floor is yours. Thank you very much, Anna. So thank you. Yeah, in a minute we will see my presentation on the screen. We don't have that. So now we have penitentiary a population that's around 42,000 people. We have 87 penitentiary institutions. Of the healthcare facilities is 100, but 10 of them are on temporarily occupied territories and 10 in the territories of military activities. So the Center of Healthcare of the State Criminal Executive Service of Ukraine. So we have 2 specialized TB hospitals. There were 6 of them before the war and 5 multi-profile hospitals. If we talk about HIV co-infection, so in these institutions for many years, so the level of HIV infection is higher, 20 times higher than in regular hospitals. So we have about 4,000 infected populations, and that's around 8% of all inmates or detained population. If we look into regions, you can see, so we have different regions of Ukraine. So that's from 7,000 for every 100,000 and even higher indicators. If we talk about combating TB activities, so that if a person is in any penitentiary institution, it can be a pre-trial institution or prison. So they, first of all, they fill in the form about TB, they answer the questions which are asked there. Then this form is provided every 6 months. So then population with symptoms, they are selected for diagnostics. As a result of testing, if the diagnostic is confirmed, it can be on the oblast level or in a specialized penitentiary institution. So then this person is hospitalized either for specialized TB hospital or to the medical department in penitentiary situation or in a TB facility of the Ministry of Health Care. Also, we have the test of contact people. Also, we have a monitoring of the doctor. Also, if it's necessary, we can provide consultation of physiologists to exclude TB if the patient has symptoms. So if you talk about dynamics, you can see that since 2018 to 2020, that's when we have data. So the number of cases decreased almost by 300 people. And it cannot be just because we have fewer inmates. Yes, so this number decreased, but it is the issue of not enough work to identify TB cases. If we talk about epidemiology, so if we look at about susceptible and resistant, so the data hasn't changed much. And you can see if we compare, so about TB-resistant TB is almost twice as many as susceptible. And also, if you talk about effectiveness of treatment, so sensitive TB is treated better, about the level of 78%. And if we talk about DR resistant, that's about, effectiveness is about 31%. If we talk about the main cause of death, for all people who are detained in prison, TB is in the 5th place. First is cardiovascular, Then we have suicides. Then we have the gastroenterology, and the fourth, that's we have HIV, and then we will talk if TB is identifying with the person who is in pretrial institution. That's one algorithm, and different algorithm if the person is already in prison. In the pretrial institution, these are people who haven't received their sentence, so investigation is still going on. And also, pretrial institution, they are in big oblast cities. That's for you to understand the situation better. So if it's without bacterial emission, so most probably they will be treated in the pretrial institution. All drugs are accessible for side effect, and physiologists are present there too. Also, all different types of diagnostics are available too for molecular genetics, but if we talk about bacteriological and about the level of resistance, so then it will be done in the on the regional level in the lab. If we have bacterial emission, so most probably this patient is going to be transported to a specialized facility. This patient either is going to be transported to a specialized TB hospital. There are 2 of them in penitentiary system, and they will be placed in a specialized department of the pretrial institution, because the patients who already received their sentence and the patients from pretrial institution, they cannot be held together. Also, this patient can be placed in the oblast level TB facility, but there are certain conditions for this. First of all, there should be a special ward for patients like this with bars and other conditions, and also there should be security 24/7 provided for this patient. Usually these are 4 people, people of personnel who can provide 24/7 security. If these conditions are available, then the patient can be placed in the ward on the regular TB hospital. But if the TB is diagnosed in prison, so usually they are not in big cities. These are villages or small towns. And also, these are people who already are doing their sentence. And also, I would like to add that now, so the norms regulation that we have now, it says that TB in prison is not treated, which means that this patient should be transported to a specialized TB facility, either to a specialized TB hospital, which is a part of penitentiary system, so they should be placed in diagnostics department, and when the diagnosis is proved, and when they know if it's acceptable or resistant, only after that they will be placed in a relevant department. But here I would like to show you the process of transportation, and I would like to talk about it a bit more when we talk about challenges, because everything is not as good if we talk about this particular step. If the patient has TB and this patient is in critical condition, then this patient can be placed in the nearest regional TB facility where they can be treated. But I'm asked to speak a bit louder, so I will try. So then they can be diagnosed and treated there. When we talk about molecular and genetic research on GenExpert.
I was listening to my colleagues who were speaking about the system that has been developed in the country, a molecular genetics system, and in the penitentiary system in Ukraine, we also have molecular genetic system of diagnostics, but it's used not only for TB but for many other infections as well. Gene expertise equipment is used to carry out 4 types of tests. First is TB diagnostics using ultra cartridges. That for 3 years, this equipment is also used for testing HIV load, viral load. Then we introduce hepatitis C tests, and for more than 10 years we've been carrying out also COVID tests using this equipment. Access to molecular genetic tests is shown on this map, and on each region you can see different colors, which mean that each region has a gene expert equipment except for one region. Sorry, we have to go back. Here's the map. So we have Zakarpattia region. Uzhgorod is here. They don't have their own equipment, but they belong to a united branch in Ivano-Frankivsk and Chernivtsi, so they can transport the material for testing to these neighboring regions. But the distance is quite large there, and we use the services of our colleagues from the Ministry of Health. So they have this Oblast Anti-Tuberculosis Center and HIV centers as well. Then we have 30 pieces of equipment available in the penitentiary system, but 5 of them are now in the temporarily occupied territories or recently liberated territories. They are marked with red on the map, and they have 25 units functioning at present. Then we have light blue color. They have 6 color cartridges, which is old type of equipment, so they cannot use XDR cartridge. And this darker color is used to mark the regions with new equipment that is suitable for using XDR cartridges, which is newer equipment. Molecular genetic testing will play a big role in diagnostics, not only of TB, but of other diseases as well. So back in 2019, we started drafting orders at the level of the local branches, prescribing the routes and types of transportation for delivery of material for testing. The schedules were coordinated with NGOs working in different regions, funded by the Global Fund or other organizations, and with support of the USAID project. At present, non-governmental organizations deliver biological material, but not only NGOs, but staff members visiting different branches, different agencies, also deliver and transport biological material. So lab screening for TB is carried out by 20 laboratories at the first level and 2 laboratories of the third level. We have certain positive trends, which is complete human resource provision in these labs, additional payments were introduced in these labs. Then they have organized logistics within the boundaries of the region, and they received high-quality technical support. But the issues include ensuring quality of selection of people for sampling, absence of people, controlled collection of material is also an issue. Then there are certain restrictions that are introduced, then the prisoners have to be transported somewhere. Then the patients can refuse to provide samples and undergo treatment, and then there is a problem of the long distance transportation need. On this graph you can see comparison of testing information for 2018 and the first 11 months of 2022. In 2018 we had 890 people who were tested, and 2021 we already had more that almost 6,000 patients screened for TB. So we see the increased rate of detection, because in 2018 we had 5.1% of detected TB, and in 2021 this figure exceeded 12%. So the probably would achieve the same level in 2022 if it was not for the war. So in the beginning of the war, during the first 4 to 5 months, we had decreased number of tests, logistics undermined, and people left the system. So we had a lot of painful issues that prevented us from achieving our goals. But in summer this year, the number of tests for TB increased, and you see we already have 4,100 people with a rather good level of detection rate. Identification, I mentioned that for different regions. You can see that there are some regions that are leaders in TB identification, demonstrated rather good levels like 15, 26% in Odessa region, in Kirovograd region, Zhytomyr region, Ternopil. And they had rather high absolute figures, and which were used to calculate the level. So we also identified cases of MDR TB. If we look at the year of 2021, the share was 50% of MDR TB, and in 2022, this share increased to 65%. Then we have a lab network for TB diagnosing. It's headed by the Central Reference Laboratory of the Ministry of Health. We have 2 laboratories at the 3rd level, and we used to have 7. 5 labs were lost during military activities. They were almost not damaged, but are closed for the time being, and we're talking about reopening these hospitals and labs. Then all these labs provide diagnostics not only for TB, but the whole range of molecular and genetic tests that I mentioned before. Then there are 44 labs at the 1st level, and in 20 of them we have GeneXpert equipment. As to the next slide, I was thinking whether I should show it or not, but I decided to show it to you. So if you look at this blank, let's first at the colored regions first. So these are the regions where special TB hospitals were located, including labs of the 3rd level. We see that accessibility of bacteriological tests before the war was provided only in these colored regions. Now, when the war started, they still provide the bacteriological tests, so we can go to any laboratories. All these blank regions now provide tests, bacteriological tests for people kept in pretrial detention facilities, and we are very grateful to the staff of these labs. Conclusions: 100% of coverage of anti-tuberculosis drugs with support of the Global Fund. We have 100% of the drugs treaty for controlling adverse effects of anti-tuberculosis drugs. We have 100% of lab equipment. Then we have much better cooperation between civilian and penitentiary sector. We have various facilities and specialists of the Center of Public Health or the specialists from the Institute that are involved in diagnostics. When we have physiologists working in anti-tuberculosis facilities who work at the same time if in pretrial detention facilities, it's very useful. They know how to treat people, how to help therapists, general practitioners, how to help other specialists. So they involve physiologists who help them not only in treatment of TB, but in diagnostics. Accessibility of bacteriological tests is almost 100%. This development of the system of molecular genetic tests are now used as the primary test for TB diagnostics. Now we use new anti-tuberculosis drugs and includes rifampicin as the drug for preventive treatment of TB. So these are the achievements we can demonstrate this year. Issues: lack of personnel in the labs, including new requirements in the sphere of quality management, lack of skills and time for lab specialists, for lab staff, for self-development, then insufficient examination and checkups of lab equipment. We're not talking about bacteriological equipment now because it's checked with the fund, with the resources of the Global Fund, but we are talking more about clinical equipment here. Then incomplete compliance of lab premises with the internal control requirements, and then we lost 4 specialized hospitals out of 6. So patients from the lost hospitals had to be placed in the existing hospitals, and we had accompanying issues with ensuring infection control. Then we had hospitals that was purely female because women do not have a lot of TB instances, and we had to bring 100 men to that hospital, purely female hospital, and now we have unprecedented case when women and men are located simultaneously in one colony, in one prison, and that raises a lot of issues related to separation of these people. Then in some regions there are no oblast anti-TB facilities like in Chernihiv, and there are no services provided for people in pre-trial detention facilities. We also have huge human resources problems, in particular specialists who select people with suspected instances of TB. We have one specialist who performs a lot of functions, but the TB interests are not in the center of their activities. Then we have stigmatization. New people are not willing to come to the system, and if they do come, they do not stay for a long time. And then we also have now the problem with energy provision, especially in pretrial detention facility hospitals. So for several weeks, we've been receiving phone calls and information that equipment goes out of order and malfunctions because of the electricity problems. And the situation is especially bad in Odessa city and Odessa region. Then we have gaps in legislative regulation of anti-tuberculosis activities, which means that medical premises are rented by the state penitentiary service, and they have these clashes of requirements, healthcare requirement and penitentiary requirements. It's not in the interest of the patient.
З передачі хворого.
So the process when the patient leaves penitentiary system, when it doesn't work automatically, that they are sent to the hospital of Ministry of Health. So police, they need to look for these patients. It doesn't always work, and especially during the war, it works even worse. And NGOs, they come with their assistance. They have different system of support of these patients, buying tickets for them, giving them extra food packages, giving them some money if the patient is registered in a regional level TB facility. And also another big issue which I left till the end, that's the absence of the correct medical transportation. So I mentioned this before, that when we need to transport the patient to a specialized hospital, and it's a problem because patients cannot be transported like as one individual patient, and it has to be a group. For TB, a group is always bad, and the group is selected not by medical indicators, so it can happen. There are people with bacterial emission and people who are not infectious, so these can be people with different profile of resistance. We understand that. So it takes some time. So sometimes it takes from a few weeks to a few months to collect this group. And unfortunately, I have to say they don't always follow the rules that we got used to this when the patient is wearing a mask and the personnel is wearing respiratory equipment, protective equipment. And also during the wartime, it's important that the National Guard, they are organizing transportation, but now we understand that National Guard, they have different tasks in the country, and most of them, they are the front line, which adds additional challenges. That's all from me. Thank you very much for your attention. And if you have questions, I probably will answer in the chat. Thank you. Thank you very much, Marina, for this very comprehensive presentation. I have to say that always laboratory professionals of penitentiary system, they participate in trainings, in conference seminars, and we organize also the external control of quality with us. They are always with us. We always work together. And it's real unfortunate now that some professionals, laboratory professionals of penitentiary service, they don't have a job because of the situation in the country. And I truly hope that penitentiary service and the leadership of the service, they will find jobs for these people because they are trained, because so you cannot become bacteriologist in one day. So it's very concerning that we can lose these professionals. That's the first thing. And secondly, I would like to say that international donors, they are ready to finance services for penitentiary system in the regions where there is no possibility to get the services. And so we really hope that our patients in penitentiary system, they're going to be checked, diagnosed and treated. They will not be out of our attention. But professionals in these areas, this is our concern because 2 laboratories in Kherson are not working, and they have very powerful team in these labs. And in Zaporizhia region, the same, in Mykolaiv region. And we really feel a lot of pain that these teams are basically out of jobs. Now we discussed it with you, Ms. Marina, many times. That's my comment. I have to say it here and now. Thank you. Thank you very much, Ms. Anna. That is true. I said that out of 7 labs, unfortunately, only 2 are functioning, and now, it is discussed whether to reopen hospitals and labs, but you stated really correctly that it is artificial work in some way. Our physiobacteriologist, we needed to work for many years with them, and because they now have a lot of knowledge and expertise, and we will try to work with them as soon as we understand how we can work with them. We don't leave them behind. If it's possible to get in touch with them, send them some presentations, so to provide online training, even if they are not working practically. So we are engaging them in different events. But of course, we could not work with people who were in Kherson. But we could work with lab specialists from Zaporizhzhia region, Kharkiv region, and Mykolaiv region. We are always in touch with them, and even I would like to add that professionals of Kharkiv lab, together with their patients, they moved to Zbaraj Rayon, and they continue their work. They have employment. These are 2 doctors and 2 lab specialists. They lost some others, but we believe that when we can go back to the premises of labs and hospitals, we'll find them back and work with them. But if they left and they found some other place of work, we will need to try to see what we can do next. But it is true, it is very painful to lose these professionals, even for a short period of time. Thank you very much, Ms. Marina. And I have one more comment. We know about our professionals of Kharkiv region, of specialized TB hospital and the lab of this hospital, because they went successfully of this external quality control and they work in Zbaraj lab, specialized hospital, and they have small backpack, but people are working as a team and they help each other. And I'm very happy to see something like this, because in these conditions, it shows their professionals, their humanity, and these factors are very important. And I think that they are a really good example of partnership and cooperation with colleagues. So I want to thank your professionals. And now I would like to move to the last very interesting presentation, which will be made by Alexander Chernov, lab specialist of support TB control efforts in Ukraine project. We usually call it just PAS, but this is a very reliable partner, and Alexander as well. And the presentation is called The Opportunities of Implementation of Sequencing on Laboratory of the Institute as the framework of project of support TB control efforts in Ukraine. I have to say that we already started working in this direction, and Alexander will give us more information about this work. Thank you, Alexander. The floor is yours. Thank you. Thank you, Anna. Good afternoon, dear colleagues. I want to draw your attention the opportunities of using sequences in the lab of microbiology and chemistry. And I would like to look into basic issues about what sequencing is, why we need it, and what modern platforms are used for this now. As we know, sequencing, that's so the primary type of polymers, and in this case, this the sequencing and which you can see on the slide. Why we need to use sequencing? We know the DNA includes instruction for the functioning of the organism to improve its life and procreation. And if we understand this sequencing, it allows us to understand some processes, how the organism is functioning. For the first time, sequencing, basically it started in 1977. There was first publication on Sanger technology, which is still used. This is the first generation, but it is quite spread in the past and now because it's really accurate. But progress is not as lagging behind. So we have a new type of sequencing. This is a new line of technologies which has advantages. First, it's speed, because sequencing is done in mass parallels, then micro scale. It's all in micro vials, so it's very convenient. And it gives us good opportunities. So speed, I already mentioned. It's much cheaper if we use this new generation of sequencing in comparison to the first generation. But also this new generation sequencing is moving forward as well, and I would like to talk about some technologies which are of the sequencing of third generation. So one molecular sequencing in real time. So this technology is, or this technique is done that in one molecule is built in the second DNA using nucleotides which are fluorescent marked. So basically nucleotide is fixed there, and this approach has advantages. First of all, it's one of the two methods which are used now, and this is a big advantage because we can sequence not short reading but long from 1,000 to 10,000 kilobase. And sequencing has pretty good coverage, and this sequencing is happening in real time because we see the whole process at the moment when the molecule is synthesized. So the disadvantage is low accuracy now. Also is the size of the platform, and the second technology, also it is connected to the previous technology, is Oxford Nanopore Technologies. And here the principle of sequencing is through the pore on membrane under pressure. The molecule of DNA goes through this pore like a thread through the needle. As nucleotides, they have their size and characteristic. So this pore is closed, and then it is fixed. And this technology is real-time technology. And I would like to say the biggest advantage of this platform, as you can see in this picture, that's the size. It's portable. It's basically, in comparison to other sequence equipment, it's very small. Second advantage, that's low cost of platform and the service for the platform. And it's also the length is about 2 megabase. And also we can get a real-time result. And also there are certain disadvantages. That's low accuracy for now. Also, and we also have like really big unprocessed incoming files.
Now I would like to talk a little bit about the existing platforms for Oxford Nanopore technologies. All these types of equipment use the run-through chamber of one type, so they have increasing number of information that it can provide. Mini Eon is with one chamber up to 50 gigabyte, and next one can proceed a larger amount of information, and the biggest sequencing machine provides a capacity of Proteneon with 12 terabytes of information. You can see this table reflecting Illumina technology and Oxford Nanopore technology. You can see the through capacity of each of the platform using genomes of TB mycobacteria. We can see that 100 times coverage MySeq platform and MiniSeq has a capacity of the same amount of mycobacteria as Eon. And I would like to focus your attention on the fact that these two platforms can compete for sure. And as of today, we have the most popular platform. And it is popular because of its high level of accuracy and low cost of tests. And I think that a significant advantage is its proven technology, because the technology accounts for 50% of sequencing worldwide in all the labs. So this platform has a wide range of application and it works pretty fast. So we are talking about the ability to sequence the formatted DNA, and it's plus and minus at the same time for this platform, because the previous platforms used for the previous ones are used for longer sequencing, and this one is used for shorter. So it's not able to identify structural variants or genome parts, and it has a lot of repeated elements, so it's not able to provide distinctions. And here you can see that this Illumina blood equipment provides this MySeq platform, and it's used by the majority of labs. And a very wide popular model in the world is MiniSeq with a lower through capacity. Illumina also created new platforms with the same technology, but with improved principle of operation, because all sequencing requires many days of preparation of material and preparation of the device. And this new generation of the equipment improves these requirements. And we also have a machine with the possibility to process up to 16 terabytes of information. And what are the main prospects now for application of sequencing? There are 4 areas, and one of them is phylogenesis, the identification of the ways of transmission, determinants of resistance, and determinants of viral load. As to the resistance, it's more or less clear, because in order to receive a quick and efficient treatment result, we need to understand the entire range of resistance and sensitivity of the microorganisms with which we work. And this sequencing provides us with information about the whole range of sensitivity and resistance. I think this tool is quite promising for determining the level of resistance. As to the standardization of identification of resistance, it's very important in sequencing because last year we received the first standardized catalog, and this year we are waiting for an updated and revised catalog for provision of results after the primary work. So that standardized interpretation is extremely important for receiving optimal results. Here you have a comparative table stating the drugs and the range of accuracy. So we can see that at the level of targeted sequencing, this range is quite wide. As to other methods, we see the entire spectrum of characterized parts. Here you see one of the popular schemes of using the sequencing methods. The first option is for identification of the presence of TB using GeneXpert Ultra. And in the case of reef resistant and reef sensitive cases, we use the results to we select the treatment regimen, and then we send the samples, the second of which is processed for 2 weeks, and then we carry out the phenotypical test for drug resistance, and after that we have this full gene sequencing. And for this molecular sequencing of genome and targeted genome, we received not only information about resistance, but also information for targeted sequences. We received the typology, resistance, and that enables more personalized selection of individual treatment plan. So for us, it gives a possibility to carry out phenotypical analysis and a wider identification of the drug resistance range. Epidemiology. We know how important it is to use genotypical methods for identification of the transition ways. We now bring this system closer and closer to the clinic, so we can use this equipment to receive a wider range, because we carry out sequencing for the entire genome. And as a result, we received a higher discretion level. So on the left side of this slide, you can see an example of analysis carried out in one of the South American countries. So cluster analysis was carried out, and it provides the number of nuclear morphisms divided by clusters, and you can see how the transition goes from one cluster to another. As to phylogenesis, you have to remember here that the microorganism is in the center of your attention, because this TB microbacteria can be more resistant, can be more prone to develop resistance, and there is regional specific features, and everything depends on geography. So phylogenesis of TB is presented in the form of a tree that you should now remember about the process of sequencing. And I'm going to talk to you about how it is implemented in the laboratory of the National Institute. It's done with financial support from the FAST and the USAID. The laboratory now has a range of equipment for sequences. You can see these main devices here. Last year, a rather in-depth two-stage training session was delivered on target sequencing, and the specialists were working and were trained, and now they carry out this primary analysis on their own. Approximately 50% of the whole work in sequencing is analysis, and the tools that are used for analysis will determine the end result. So together with the specialists from the lab of the institute, we install software or the application. So we have three options for the applications, and each of them can carry out analysis in the identified directions. This year we started research work on identification of TB microbacteria, resistance to new drugs. So it's carried out among TB patients in some regions of Ukraine. Lab specialists, with support from the project specialists, developed a protocol and SOPs for all stages. And this protocol has been signed, and work was commenced on its implementation. So we've gone along through a very cumbersome stage of collection and processing of materials, and now we are about to start sequencing, and after that we will proceed with data analysis. Thank you for your attention. Thank you, Alexander. And I would like to add that this is very strong work. Sequencing is hard work, and if someone thinks that it's like XDR or GeneXpert, you are mistaken, because even if when we have these mobile devices for sequences, these do not mean a lot, because you saw how the process looks like. So what needs to be done before we actually start sequencing? And this requires a lot of hard and careful work for preparation and selection of materials for sampling. And here we have to know how to go about selecting the material, because research is one thing, but the purpose of this research is to provide recommendations for the regions, how our country is going to move and to which end it will implement this sequencing. And in addition to this, we have no WHO guidelines or recommendations, because we've already discussed that in clinics, it's a faster option. I'm talking about targeted sequencing. And of course, we do not exclude the possibility that clinicians will be willing to have this full genome sequencing, because it provides more complete information. So, colleagues, if we do not do something with our own hands, we cannot recommend anything to anyone, even if WHO promises that next year that they will publish guidelines on sequencing. So still we are not ready to implement it on a nationwide scale. So thank you, Dr. Alexander. And I think as soon as we have the first results, we will be informing you. We will make a very loud statement. So thank you. Marina, are you ready now to answer the questions? So there was a question in the chat, and now I want to read it out. So now we see the increased share of sensitive TB among prisoners. So how would you explain this? So the author would like to hear answer to his question. So please, the floor is yours.
Thank you. I'm a more lab specialist, but I will try to answer the question. When I said before that that RIF plus or the risk of MDR, so we can see that it increased from 50% to 65 in 22. That's a fact. But why this? So we have more of susceptible types, and the answer is. So patients are registered with relapses and first-time diagnosed TB, and now the TB diagnostics is done this way that so we can find cases which are not at late stages, so even without bacterial remission. So basically, in some way, it is. So it's like it increases this number. So and that's where we are. So basically, the answer is that we register more cases. And these are usually the cases which are early diagnosed. And if we go back to the numbers that in 2018, about 800, 900 people were tested. So then in the next years, this was 6,000 or so. So that's why And yes, Natalia is helping me that also we have more Gen expert. And I cannot remember if I mentioned this in the presentation that we really increase the number of Gen experts. We had 15 or 18, now it's 25, but that's not the only one thing. We also had in-depth work with employees who work with selection of patients, with NGOs which are assisting. And we think that that's the result of this work. So we are more under control. We are holding under control of risk patients, and we work with risk groups and those people who just enter the institution on the level of pre-trial. So we believe that pre-trial, this is like the entry gate for any infection, and we work with them really actively. I mean, professionals who are responsible for them. And I hope, and the statistics shows that we select people at the early stage of the disease. Thank you. Thank you very much, Ms. Marina. If you can write your questions in the chat, and we will try after the session to also to give you answers in writing. And I want to thank my colleagues for this really comprehensive, interesting presentations. And I think we are going to continue with our lab specialists using phones, online meetings, and we'll keep discussing these issues because that's something that is important for all of us, relevant for all of us. And I want to thank everyone for your attention. And let me close this session on microbiology and thank everyone. I wish all of us peace, and let's do everything for our victory. Thank you, everyone.
Шановні колеги, ще раз всім добрий день.
Dear colleagues, once again, good afternoon. We continue the work of our conference, and as you can see, we have some problems with timing. During the first session, we lost internet connection, and we needed to resolve these technical issues. That is why all sessions, they went down, and as all presentations are very interesting, our speakers prepared, and we decided that we would not limit them in time, so that all relevant information for doctors and all medical professionals so that they can get all the information, full information, but we have this time shift. I hope you will be understanding and patient because we are working for you so that you can receive all the necessary information. And once again, we wrote in the chat that I would like to remind you once again that all our participants who join stream, you will receive certificates, but you need to, at the end of the conference tomorrow on the last day, you will need to fill in feedback form. We decided, take into account the situation with electricity and the internet, not to have some limits about how much of the conference you need to see to receive certificate. That's why if you fill in the feedback form and if you're registered, you all will get certificates. Also, I would like to remind you that today is the last session for today, and then we'll have masterclass section. If you registered for masterclass, you need to leave the link of the conference, close the link, and use a different link to join masterclass, which you received by email. And please pay attention to this. Yesterday, not all people who wanted could join just because they didn't follow this instruction. So masterclass is a different event. You get your additional points, and so the link is different as well. And also, I would like to say that if you cannot watch the whole conference in real time, at any moment when you have electricity, when you have the internet, you can watch all the sessions on our YouTube channel, National TB Hub. It's going to be free, and so you can watch yesterday's event. It's already there if you couldn't watch us live. And today you can watch on YouTube as well. And of course, it will be available later as well. So follow our channel. Give us likes or dislikes if you don't like the conference. We will take dislikes into consideration as well. But we have a lot of relevant information for medical professionals, not only this conference, but also we have announcements about future events and everything that we've been doing by creating creating this hub and this channel. And you can also go back and to watch last year conference, and some presentations are still relevant. Now let's go back to this session at hand. So this is the sixth and the last day for today. It is about differential diagnostics of TB and other lung diseases, and a modern algorithm of diagnostics and treatment. The session is very important because we mostly working for physiologists because it is about physiology, but take into account that very often differential diagnostics is a relevant issue. So this session is very important for clinicists, so to diagnose patient correctly, which algorithm and methods you need also which lung diseases can be similar to TB, where you need differential diagnostics, and so on. And so today in our session, we are working to work not with physiologists, but pulmonologists. They are professionals in these issues. And I would like to introduce our speakers really briefly. First of all, this is Evgenia Miryutkova. It will be her first presentation about sarcoidosis. And you can see the whole program in front of you. Evgenia is a lead specialist on lung diseases, MD, and so she has a really many year experience of fibrosis and other lung diseases, of autoimmune diseases as well. The next presentation will be non-hospital pneumonias from Yaroslav Zubek, who's also the lead professional on also MD, and also he has many years of experience of intersection diseases on pneumonia. Then there will be a very interesting presentation made by Lesia Bychenko together with Volodymyr Havrisyuk. And Volodymyr Havrisyuk is the head of Department of Intersection Lung Diseases. He's a member of the National Medical Academy. Also professor, has huge experience of treatment of intersection of lung diseases, and today together with Lesia is a doctor of this department. They will share a very interesting experience of differential diagnostics and treatment of carcinoma of lungs, and I think that for physiologists it's going to be very interesting. Then about mycobacteriosis, that will be presented by our colleague from Latvia, Ginta Balode. She works in Riga, Latvia, in the East University Hospital on TB and lung diseases. And as now we are becoming more effective in treating TB, also we have the problem that there is a big number of mycobacteriosis. So it is very important to know more about this. And the last presentation will be aspergillosis of lungs. And Olena Rakalova will present that. She works in allergology and immunology in the Institute of Physiology and Pulmonology. And one of the key profiles of clinical direction of this department, that's aspergillosis of lungs, which usually is common together with tuberculosis, and for physiologists that is a very relevant issue. And we'll talk about modern algorithms and diagnostics. So definitely doctors need to have all the relevant and latest information. You can see that the session is very interesting. We have different types of lung diseases. And I think that this session is going to be interesting not only for physiologists, but for pulmonologists, and especially for family doctors who need to have a comprehensive idea about all kinds of lung diseases. And after this introduction, I think we are ready to start, and I would like to give the floor for the first presentation to Ms. Evgenia. The floor is yours. Good afternoon, dear colleagues. I'm very happy to see you all in this studio.
So we're talking about diseases of unknown etiology, and this disease takes the third place among lung diseases in Europe. This is most widespread in Scandinavian countries, Ireland, Great Britain, and also found in Northern America and Japan. Lower frequency of diseases is registered in China, India, and African countries. Most often, people suffer from this disease at the age of 20 to 30 years. And there is another peak, which is more typical for women, and it's found in women after 50 years old. The frequency in women is a little bit higher compared to men, and it was also mentioned that in the USA, the black people get sick with sarcoidosis more often than white people, whereas worldwide 80% of white population more often have sarcoidosis. So sarcoidosis affects any organs and system, but more than 90% of cases are reported in the lungs. So more often, pulmonologists are the specialists addressing this disease. Second place is taken by liver. So 65% is the figure received from histological tests, and only 10 to 20% of patients demonstrate disorders of the liver functions. Third place is skin and joints. After that, the disease affects skin, which is pathogenic syndrome for sarcoidosis. Then it can also can affect heart, eyes, and and the system. Here you can see the immune pathogenesis of sarcoidosis, but its disease develops in more prone people that after being triggered develop immune response, resulting in development of granulomas. People have benevolent progress of the disease, and they either get cured by themselves or they use immune suppressive drugs to cure the disease. 30% of patients develop fibrosis, and they sometimes demonstrate chronic stages of disease, and for quite a long time, treatment is necessary, and the treatment duration exceeds 20 to 36 months. Diagnostics requires histological confirmation of the diagnosis, and then assessment of development stage of the process should be carried out with the help of X-ray. Then there is a need to assess the progress of disease and to assess the need to administer treatment. As to the histological diagnostics of sarcoidosis, in 2020, American Thoracic Association issued guidelines for sarcoidosis diagnostics, and they provided a clear description of the need for biopsy of the nodes when it's necessary and when not. So we have to remember here that in general, every doctor knows that they have to start with a clinical examination of the patients, and attention should be paid to the syndromes that are typical for sarcoidosis, such as Lerfgren syndrome, Heerfeld syndrome, and and nodular erythema. So when they see these clinical manifestations, there is no need to carry out biopsy of the lymphatic node, and there is no need to carry out histological diagnostics. So if when we see bilateral adenopathy, there is no need to carry out this type of test, even when symptoms are not there. Then Left-Gren syndrome, which I mentioned, is characterized by bilateral mediastinum lymphadenopathy, nodular erythema, and polyarthritis. Syndrome, Herford syndrome is pathogenic for sarcoidosis, and it demonstrates the presence of uveitis, then polyneuropathy, and ear and ear swelling. So on this page picture, you can see this erythema nodosum. You can see them on the shin area and lupus pernio. So the woman developed this syndrome on the face, which is frequent, and around the tattoo. So you have to pay attention to the fact that skin sarcoidosis is very often located around tattoos, scars, and other changes on the skin. When we are talking about diagnostics, we start with clinical examination, and I mentioned the basic syndromes to be noticed. Then we have X-ray diagnostics of sarcoidosis, which is also very important. On this slide, you can see first stage of sarcoidosis. You see the classical situation when we have bilateral lymphadenopathy, when with increased parts of the alveolar group. So you see first stage of sarcoidosis on the first page with increased bronchial and pulmonary nodes. On the slide below, we see even increase of all the nodes. So you have this tube syndrome, which you can see on an X-ray picture. On the computer tomogram, you can see first stage of sarcoidosis above, and below you can see lymphogranulomatous. So you can see all these nodes that are increased in all parts. So you can see that this picture will have clinical syndromes such as fever, increase of other groups of nodes, and in the first stage of sarcoidosis, people usually do not demonstrate any symptoms, and or they have slight complaints such as coughing, maybe some slight pain. On this slide, you can see second stage of sarcoidosis. In addition to bilateral increase of nodes, you can see dissemination in both lungs. Then on this slide, you can see X-ray, the picture of sarcoidosis diagnostics with the connecting tissue changes, such as systemic red lupus, and you can see increased nodes. These are real pictures of patients examined in our clinic. So the person complained about fever and sweating. So computer tomography was carried out, and these are the changes that we saw, the dissemination in the lungs. The patient was sent to biopsy, and in that case, nothing was demonstrated in biopsy because they only found fibrosis. So in this case, when we have this differential diagnostics of these connecting tissues and sarcoidosis, we have to pay very careful attention to clinical examination and collecting data from the patients. So this patient, she had fever and pancytopenia, the decreased number of leukocytes, thrombocytes, and lack of ferrum in blood. So that all can be a sign of disease of a connecting tissue and not sarcoidosis. On this slide, you can see the basic differential diagnostics criteria and their difference from sarcoidosis and connecting tissue diseases, because in patients with sarcoidosis, we have normal blood indications, we have albumin, normal leukopenia, anemia, and usually the C-reactive albumin is increased for the connecting tissue diseases, and we have this ANA titer 1 to 40, which means that it's not a systemic diseases, which can be a sign of sarcoidosis. If it's higher than 1 to 60, then definitely it's the sign of a systemic disease. And then during more detailed analysis, we can carry out further blood tests. So when you want to find some specific symptoms, you have to continue with that. On the left side, you see the second stage of sarcoidosis and the pneumoconidose on the right picture. In this case, we excluded sarcoidosis as a result of a histological test, because both pictures have dissemination lymphadenopathy, and in both cases, patients complained only about increased tiredness, some coughing, and panting. So we only were able to find the reason for that after histological test. So we had this collected a professional history of the person to be able to diagnose the disease. Here you have the third stage of sarcoidosis. You can see dissemination in both sides of lungs in small nodular centers, but no lymphadenopathy. So sometimes it's difficult to diagnose because the clinical picture is similar to disseminated lung TB, because sarcoidosis usually has small complaints or no symptoms at all, and it requires lab diagnostics. And you had a very nice presentation about lab tests that are carried out. But I would like to note that this skin test called MON2 test will be negative for patients with sarcoidosis, but in this case we have to exclude other diseases, to exclude TB, and if we establish that it's not tuberculosis, then we're thinking about sarcoidosis. Now we have the fourth stage sarcoidosis with fibrosis in lungs, and in this case, in principle, it's not important which disease caused this situation, because it's not possible to cure. It's progressive fibrosis, and as a rule, it's sarcoidosis of the fourth stage can only be diagnosed if the person came at the second or third stage. Very often we receive questions whether there are any lab tests that are specific for sarcoidosis. So all ferments and all these ferments can be increased or normal. So the normal level does not mean that it's not sarcoidosis. So this APF IL-6 demonstrates that the processes are active, but if they are normal, then it doesn't mean that the person is free from sarcoidosis. And when we have increased level of IL-2 and TNF-alpha, demonstrates progress of sarcoidosis, progressive development. But if they're at a normal level, again, the person can have sarcoidosis anyway. So 2/3 of chronic disease is reported for 10 to 30% of patients, and sometimes we have benevolent forms of sarcoidosis. Unfortunately, 2/3 of patients have this type of disease. So according to the latest recommendations of the European Respiratory Association, include minimization of the risk of disability, death because of lung disorder, or decreased livelihood, and it should and it usually coincides with the risks of accompanying pathologies and decreased quality of life because of the use of glucocorticoids and other types of therapy. So first of all, we have to identify whether there is a need for treatment for the patient. And we have to remember that patients need treatment only if there is a threat for their life. So the high-risk criteria are lung hypertension, lung fibrosis, the progressing processes in lungs, and decreased quality of life and suppressed breathing function. The main drugs to be used are immune suppressive drugs, and glucocorticoids usually include prednisolone, and immune suppressive drugs are methotrexate, which is the first choice drug worldwide. Then hydroxychloroquine can be used as well. Most often it's used as an additional therapy and not the first choice drug. And the third-line therapy includes infliximab and adalimumab, which also demonstrate a high level of efficiency, but still they are very toxic and result in a lot of relapses. Thank you very much for your attention. I wish peace to everyone and a victory of Ukraine.
Дуже цікаво.
Thank you very much. It was very interesting, especially when we talk about differential diagnostics and the modern methods of diagnostics and treatment. It is very important to know, I believe important for everyone. And the next presentation is going to be on community-acquired pneumonia. And we are going to listen to Yaroslav Zublak. And after that, so good afternoon, dear colleagues. Thank you very much for inviting me. So let's talk about diagnostics of community-acquired pneumonia. So it is still big and social issue. And now there is classification where we can split pneumonia into hospital-acquired and community-acquired. That's connected with the place where patients get infected, and we can differentiate pathological process. If we talk about community-acquired pneumonia, there are a few subgroups without the influence on the immunity, also with some other conditions, for example, HIV, which they lead to lowering the immunity. And also, if we talk about community-acquired pneumonia, so it was diagnosed in the first 48 hours from the moment of hospitalization. And it can, the symptoms can be fever, cough, certain difficulty breathing, pain in chest, and also the changes in the lungs without any other possible alternative. The most important documents which we use in our everyday work, this adopted recommendations, which was created by the specialists in pulmonology and physiology. And also, at the end of 2020, there was a huge paper under academic fashion collected the work about diagnostics, treatment of non-hospital pneumonia. We believe that this diagnosis is correct if we have RF infiltration, plus two clinical conditions, for example, the acute beginning and fever, cough and sputum, also physical symptoms, and it is probable if we have history, then complaint of the patient and physical symptoms. And if we have only history and complaint, if we don't have any X-rays or any physical symptoms, we can talk about low probability. So if we talk about diagnostics, so we used CT scan, and this is definitely effective. We work it for diagnostics, for clarification of the previous checkups, also to find the changes. And for example, we can use it instead of invasive method of diagnostics. Also, we can use CT. We have pathology of bone and muscle. And now we have three main types of pneumonic infiltration. So that's pleuropneumonic, bronchopneumonic. So this is the first example. So this is like it's spread for the whole wall of lung, and usually this is so streptococcus and pneumococcus, and usually we have like the symptoms of the respiratory broncho. So then if we have pneumatic, so you can see it on this side, and then interstitial, so we have the symptom of this mated glass. So you can see the example of this pneumonia. And usually it is connected with having some other diseases which influence the immune system. And usually you can see this, that it is quite typical for COVID-19, which leads to this phenomena. And you can see a few examples on this slide. Very clearly, we have symptoms of diagnostics during COVID-19. So usually it is, so we have the symptom of mated glass, also you see the example and consolidation in is so the so we other symptoms are less common, but you can see that COVID-19 is different from pneumonia because the structure of the damage is different. And here you can see a different list. So we have virus pneumonia and virus bacterial pneumonia. And we look here into this, the way how disease started, and also some lab indicators. The change of lymph nodes, leukocytosis is quite common for bacterial pneumonia and less common for virus virus pneumonia. Also, if we talk about procalcitonin, it is very important to look at these indicators. It's included in this diagnostic table. And of course, the changes in the lung, where we can use some X-ray diagnostics. So because you can see the differences between these two diseases. So if we talk about the treatment, take into account the bacterial microflora, which is usually dominating during non-hospital acquired pneumonia. So if antibiotics are assigned on time, so we can see pretty rapid regression of infiltration. So the long term, it can be 6 weeks. Sometimes we can register some symptoms which can take longer than 6 weeks. It can be resistant flora, so it can be also alternative diagnosis, or it can be some serious comorbidity. And also the consequences is the forming of local fibrosis. So some complications, pleuritis, so it is about the collecting of the liquid. If we talk about this complication, so usually it happens for about 30–50% of patients. Also, another complications can be so empyema or pleuritis. So we have also the number of leukocytes can go higher than 25,000 milliliters, and also some presence of microorganism. And lowering of pH, it's lower than 7.1. And usually it is it's anaerobe, which causes this complication. Also, another complication, which with abscess of lung. So when we use CT, we can see the higher density of infiltrate. So usually the density is like plus 15 or 10 of household unit. Also, so so we can see the changes in bronchs, and also the part of the damaged lung can increase. And you can see here the differential diagnostics. Also, we had like the cancer here. You can compare it with sarcoidosis. It is so. Sometimes is common disseminated damage of lungs, so it can spread into some big fields, which reminds of consolidation, and sometimes it also like patients have some symptoms which can be similar to community-acquired pneumonia. Of course, tuberculosis, it can be another disease that can be confused with this type of pneumonia, and we need differential diagnostics. And of course, that is very important to use different microbiological types of diagnostics that we can confirm the etiology of the process. Also, we have different types of different types of pneumonia or non-specific pneumonia. We need to take into account when we have differential diagnostics to differentiate it from community-acquired pneumonia. You can see the difference because we have the symptom of reticular changes in the lung and this mated glass type. Also, we have cryptogenic organizing pneumonia, which you can see the differences here. Usually, it's more common for people of older age, and antibiotics do not help in this, but there is effective treatment for this, and also take into account the specificity in this disease, so we need to have differential diagnostics. Even so, some cardio diseases, they also can be similar to pneumonia because the changes are a bit similar, so it's very important to take this into account during differential diagnostics. So also you can see that about the problem with arteries in the lungs, and you can see a few examples of the scans, and we can see the difference that differential diagnosis can be really complicated. We need to take into account different factors and markers, and to check the lung blood circulation, also ultrasound, together of fluorography and CT, and take into account different factors to diagnose correctly and timely to choose the proper treatment. And another interesting case, here we see this minted glass symptoms. It's alveolar proteinose. You can see here the difference in alveolus, and usually we need to have biopsy of lungs, and you need to use a lab to find all these masses in alveolus. So this community-acquired pneumonia is still very big problem. Differential diagnostic includes at least 100 or even more possibilities which we need to confirm or exclude. And of course, this topic is developed in a dynamic way. And today, of course, we focus on our attention on everything that we can read in new publications, in practical activity, and we try to implement all these new recommendations, and we try to have raise awareness among family doctors and general practitioners to increase the effectiveness of diagnostics and treatment of patients. Thank you for your attention.
Thank you. It was a very important and relevant presentation on pneumonias. Dear colleagues, again, I encourage you to leave your questions in the chat. We will record everything, and during our discussion, we will answer all your questions. And now I would like to give floor for the next presentation for lung carcinomatosis. So, Alessa, the floor is yours. Good afternoon, dear colleagues. I would like to make a presentation on carcinomatosis in differential diagnostics of lung disseminations. I would like to remind you very briefly that carcinomatosis is the secondary disorder of lung tissues when the patient develops malevolent swelling. Usually it appears a result of hematogenic processes or through diaphragm. According to the autopsy data, the metastasis in the lungs most often develop during sarcoma and the damages of breasts, urinary system, and others. And clinical manifestations are not significant, and very often these developments provide result in no symptoms, and when it goes to various parts of the lungs, then the patient develops coughing. And we have to remember that this is the secondary neoplastic process when the swelling or cancer cells are transported by the blood system, and that can be seen on various X-ray pictures as kind of nodular changes, various consolidations. There is a newly created groups, and then when it results from lymphogenic processes, we can see that that fact complicates the diagnostics process very much. And lymphogenic carcinomatosis of lungs results in panting when non-productive coughing and general weakness. And when these respiratory syndromes develop, we can see a very fast progress, and within a very short period of time, they become more serious after they first appear. On this slide, you can see a patient of 23 years old. He came to us with complaints about panting, some coughing, and during the computer tomography, we saw numerous changes which have very clear boundaries, and they are evenly distributed in lungs, and it's very typical for sarcoma. When we continued examination in the Cancer Institute, we found the primary swelling that was located in the area of thigh break that he suffered from several years before. Our next patient complained about severe panting, non-productive coughing, and fever, general weakness, and tiredness. And when we carried out computer tomography, we saw various changes, nodular transformations, consolidations, and then changes around bronchial vessels and pleural changes. So we can see these systems typical for lung sarcoidosis, which is bilateral then we see these pleural changes, and which are not typical for sarcoidosis, and then we saw the clinical symptoms which are not typical for sarcoidosis. So proceeded with examination, and we found bronchial cancer on the right side. And we see on CT, we see metastases that are developed in lungs through lymph and blood. On this slide, you see the CT picture from another patient, female, who was diagnosed with breast cancer, and here we can see metastasis of that cancer in her lungs. For lymphogenic carcinomatosis of lungs, it is more typical to see changes on both sides, so it should be bilateral and more evenly distributed. So this more localized picture is typical for breast cancer and for lung cancer. On these pictures, you can see, on these two tomogram pictures, you can see progress of carcinomatosis, and only during a month and a half passed between the first and the second picture. As we can see lymphogenous carcinomatosis, you can see interstitial changes, reticular changes, and the most important for the purposes of diagnosis, the symptom is thickening of secondary lung parts. You can see these partitions that are very bright and very clear. The tissue of lung is not changed, so we can see that these nodular changes can also be seen, and thickening of bronchus and vessels are also changed. Then you can also find liquid in pleural spaces, which makes it possible for us to think about carcinomatosis. Next, female patients came to us with complaints about painting, coughing, weakness. So first she came to her local hospital, and after examination, she was diagnosed with interstitial lung disease. So she received 32 milligrams of prednisolone per day. And then doctors had further doubts, and they referred her to our institute for a consultation. On this CT picture, you can see bilateral lymphadenopathy. You can see the diameter of 18 to 20 millimeters, and these nodular contours are very clear. So we can also see, not here, but we saw the increase of paratracheal nodes, and that all is typical for sarcoidosis. And in addition to this, we could see thicker partitions, internodular, and then changes in the lung tissues. Since these respiratory syndromes were not very strong, not very severe, so the symptoms were typical for sarcoidosis, so she was diagnosed, and methylprednisolone dosage was decreased to 24 milligrams per day. Still, we have to mention that in the lower parts of lungs, now, in retrospective analysis, we can see that these internodular partitions are thicker, which are less typical for sarcoidosis, and that should be a sign for us to think about carcinomatosis. This patient died several weeks after this, and then materials from autopsy was sent to our institute. The head of pathomorphological department worked with those materials, so she prepared them for histology, and we can see lymphogenic metastasis. So the primary swelling was not found, and for us to identify the source of swelling, we carried out additional tests, but it was not located in lungs, so we were not able to find this primary swelling, so it remained anonymous. Next patient, male, came to us after treatment in his local hospital. He was 34. He had severe panting after physical exercise, coughing. Then he lost 10 kilograms in 3 months, and he also complained about weakness. So in his local hospital, he was treated for non-hospital pneumonia, and antibiotics were not sufficient. Then he was diagnosed with unknown lung disease and received corticosteroid therapy. For 3 weeks, he received methylprednisolone, but then his condition became worse. So he was referred to us for consultation. So we can see these thicker partitions in lungs, internodular, and then we saw increased lymph nodes. And we also found liquid in pleural space. The patient was transferred to surgery where we did not even had thoracoscopic test, and when we found the element of gland cancer. So he was referred to the Cancer Institute, and they found numerous metastases in bones, in stomach area, and the primary swelling was not found either. Next, unfortunately, that patient also died. Next, female patients came to us with complaints about progressive panting. She received methylprednisolone for 2 months and with no result. On the CT picture, we can see again the thicker partitions, and we see different parts of lungs with various intensity of picture, and the same patient 2 months later demonstrated a significant development of changes in the upper parts of her lungs. The patient was diagnosed with lymphogenic carcinomatosis, and she was further examined in the Cancer Institute, and they found stomach cancer. So that was swelling. These patients came with minimal respiratory symptoms, small panting, occasional coughing, and this is the picture we saw on the left. So the picture was taken when she came to us. So she was diagnosed with sarcoidosis, given this lymphoadenopathy, bilateral, and nodular changes in her lungs. She received methotrexate, and she lives far away, so she felt worse at home, but unfortunately she was not able to come to the institute, so she came 2.5 months later. And on the right you can see the picture after examination 2.5 months later, and unfortunately the picture was much worse, and the pleural effusion can be seen here as well. So if we look very carefully in the lower parts of the lungs, on the first CT picture, one can see thicker partitions that were symptoms of lymphogenic dissemination. And I would also like to finish by saying that, unfortunately, when we see such changes in the patients, this means that they have very little chances. The disease progresses very quickly, and very often when we see lymphogenic carcinomatosis, they die very quickly. And this CT computer tomographic examination enables us to avoid a lot of surgery intrusions, and it helps us to diagnose the diseases.
Дякую за увагу.
Thank you for your attention. Thank you very much, Ms. Lesa. It was interesting, and I believe very relevant and important information, especially if we talk about oncology, because early diagnostics is everything for these conditions, because it's one thing that if we can miss the first symptoms, sarcoidosis or some other interstitial condition of the lung, which is also important, but if we miss cancer and if we diagnose it too late, then for the patient is usually it's not just critical, but it can have fatal consequences. So it is very important to know about it. Thank you for your presentation. And dear colleagues, we continue. So you can write your questions in the chat. This session is very interesting and important. You have this chance, exclusive chance to have a consultation. If you had any issues with differential diagnostics, how you do it locally, where you see problems and so on. So don't hesitate to write in the chat. And now I'm giving the floor to our colleague from Riga, Ginta Balode, on the issue of mycobacteriosis.
Hello, dear colleagues, dear professors. Thank you for the invitation. My name is Ginta Balode. I'm from Riga East University Hospital, TB and Lung Disease Center. And today I'm going to share the lecture, which is called So Similar Yet Different, which is basically devoted to two similar diseases, tuberculosis versus non-tuberculous mycobacterial lung disease. And I'm just going to do the comparison step by step of both diseases. So starting with the etiology, basically tuberculosis is caused by Mycobacterium tuberculosis complex, which consists of few bacteria that can actually cause a disease. In comparison, NTM consists of around 200 species nowadays, thanks to whole genome sequencing. But clinically relevant species are much less, could be around 20, but the numbers are also increasing. There have been few nice studies that have actually analyzed the clinical relevance of those NTM species. And basically, what we know nowadays, that if we have actually isolated, for example, Mycobacterium gordone or Fortuitum, well, their clinical relevance would be rather low. In comparison, if we have isolated Mycobacterium abscessus, Ganzasii, or Malmoense, well, we are almost sure that it causes like true disease. If we talk about epidemiology of both diseases, well, basically, we have definitely more precise data of tuberculosis due to registry systems. If we compare with NTM, we are actually lacking the precise data because usually some data we have are from studies, and the majority of countries actually do not register those patients, including, for example, our country as well. If we talk about the incidence of both diseases, basically incidence of TB is much higher in Southeast Asia, Africa, Western Pacific. In comparison of NTM cases, incidence is higher in Western Europe, USA, Japan, South Korea. And there's always a question why. Is it due to the better diagnostics or there are other factors involved? And actually there have been like several studies which shows basically the trend of the diseases. Like here's like a nice study from the Japan, which shows that in Japan there have been decrease of both culture and smear positive pulmonary TB cases, but in contrast there have been like a sharp increase of NTM cases, and this is actually like a typical trend in developed countries. If we talk about pathogenesis of both diseases, and basically if we talk about TB, the basic way of pathogenesis is person-to-person transmission. In comparison, for NTM patients, person-to-person transmission would be more like an excuse just in Mycobacterium abscessus patients in cystic fibrosis cases. But more commonly, those patients are not considered infectious, and the pathogenistic way how we can acquire NTM would be through the inhalation of NTM-containing particles from soil, dust, water, microaspiration of swallowed particles due to GERD, and also contamination by hospital water systems, medical equipment. But whatever the pathogenistic way of NTM cases are, very important are host risk factors, because usually those patients will have some kind of pre-existing lung disease, some kind of immunosuppression, including drug-induced immunosuppression, and usually we will find some of these risk factors in them. If we talk about radiology and both diseases, well, of course, if we talk about TB, in majority of cases, we talk about upper lobe predominance, cavities, nodules. In comparison, in NTM cases, actually, there could be like a similar changes, especially in fibrocavitary disease. But in comparison, some studies have said that they are like thin-walled cavities with overall volume loss, fibrosis, and that there could be like much less nodulary changes around them. And the second big group of NTM cases would be nodulary bronchiectatic disease, where the dominant feature is bronchiectasis with associated centrilobular nodules in middle and lower lobes. But actually, it's impossible to differentiate between both diseases just based on radiology, because they can look actually similar. And there have also included just one case of middle-aged woman who had been diagnosed with NTM, and Mycobacterium avium was isolated. And here you can see actually like middle and lower lobe predominance in this case, varicose bronchiectasis here with some nodulary changes. If we compare both diseases based on bacteriological examination, then basically they share a lot of similarities, but still there are some differences. But the good news is that if you are thinking about TB, basically you can more or less but apply the same diagnostic methods and you are on the right path, because we use similar diagnostic methods for both diseases. So usually we start with smear microscopy, but let's say that the bad news is that this method can actually not differentiate between TB and NTM, because actually what smear microscopy gives us in the answer is whether or not it contains acid-fast bacillus, and it can be both TB, NTM, and also some other bacteria. The next logical step would be like GeneXpert test reply, and in TB cases, well, usually it should be positive, especially if it's smear positive. In contrast, in NTM cases, if we apply GeneXpert test, well, it will be negative because it's specific just for M. tuberculosis DNA. And this would be like the first sign if you have like a positive smear microscopy but negative GeneXpert test, then you should start to consider actually NTM case. The next logical step would be usage of cultures, and the good news is that basically both bacteria grow on the same media, solid media and liquid media. But actually the most important answer should be given by the laboratory, because in the case if there is evidence of mycobacteria growing, then laboratory usually does the specific MPT64 antigen testing, which is specifically positive for Mycobacterium tuberculosis complex. And if it's positive, then the laboratory gives you the answers that tuberculosis complex is growing. In contrast, if it's negative, then usually laboratory gives you the answer that non-tuberculous mycobacteria are growing. What is also very important in NTM cases, species identification, which usually on daily basis is done by line probe assay, but also like whole genome sequencing can be used. And this is very important for further diagnosis, treatment, and prognosis, because if you remember the first few slides, then basically if we have isolated Mycobacterium gordonii, then we are considering as in majority of cases as contamination, and in comparison if we have isolated Mycobacterium kansasii, it's like another story. So then, like last but not least, drug susceptibility testing, of course, very important for both diseases. So in TB cases, we of course nowadays use a lot line probe assay based tests to detect mutations and susceptibility to the first and also second line medication, but still phenotypic tests are also used. In comparison for NTM, we also use both diagnostic methods, but it's very important to notice that we are testing just specific drugs for specific species. And usually it includes macrolides, amikacin, rifampicin for Mycobacterium kansasii. And why? Because actually with NTM, in vitro and in vivo susceptibility doesn't always correlate. So that's why it's actually proved that we have to test just the specific drugs for specific species. And there I have also included just two short clinical cases. So here we have 44 years old male patient with productive cough, fever, weight loss. So he couldn't actually tell like for how long the cough was and how much was the weight loss. But here on his x-ray we can see and assume that there could be like a destruction cavity in the right upper lobe, like disseminated nodulary shadows on both sides, could be a little fluid on the right side here. In comparison, we have 69 years old female patient also suffering with productive cough, fever, weight loss, 10 kilos in 3 months, night sweats. And we can see her x-ray and also assume that there could be destruction cavities, could be already some fibrosis, bronchiectasis here. And here are their first bacteriological investigations, also the CT scans on the coronal axis, and here we can see like the nice big cavity in right upper lobe in this patient's case, and also several cavities in this patient's case. What we have from bacteriological investigations, so we can see that there are like 2 sputum samples positive for acid-fast bacillus, so 3+, it's a lot of bacteria, and gene expert test is positive, high concentration, rifampicin susceptible. And positive culture came on BACTEC in 10 days, Mycobacterium tuberculosis complex was growing. So no doubts of the disease. In comparison, in this case, there were like 2 positive sputum smear samples with acid-fast bacillus, but at the same time negative gene expert test 2 times, and it was already suspicious of NTM. Positive culture in BACTEC came in 13 days, and there was evidence of NTM growing, and Mycobacterium avium was identified. And actually both patients were drug susceptible. Mycobacterium avium was tested for macrolides and amikacin, it was susceptible. If we compare both diseases from the treatment's point of view, then I would say that it's much easier to treat like a drug-susceptible TB patient, 6 months regimen, now even like 4 months regimen based on WHO guidelines 2022. But of course, like our country as well, we are lacking rifampicin. That's why we cannot apply at the moment this regimen. And what says the outcomes that even up to 85% of the patients can actually be cured. In comparison, for NTM patients, we have to apply treatment for 12 months after culture conversion. So in the reality, it would mean more than 12 months because we have to wait for the culture conversion. And regimens are a little bit different, and they depends on NTM species. And outcomes also varies between different species, from up to like 90% cure patients in Mycobacterium kansasii disease, which is considered of like one of the easiest NTM to treat, to just around 40% in Mycobacterium avium. And also like in Mycobacterium avium, Xenopy, other NTMs, there are actually a lot of relapses, repeated infections, and they're pretty hard to treat even after those 12 months. And thank you for your attention.
Thank you very much, and it was very interesting and relevant concerning mycobacteriosis, especially now when we have to think about increased efficiency of TB treatment. Now we have decreased number of cases of TB, but increased number of mycobacteriosis. And we are looking forward to your questions, colleagues. And now I give floor to Olena Rikalova for the final presentation during this session about aspergillosis of lungs patients with tuberculosis. Dear colleagues, over the last years, we saw the increased number of mycosis in the entire world, and aspergillosis is the most widespread type of infections, and the number of cases in Great Britain since 1996 increased 4 times, and that happened because of the increased number of immune compromised patients and improved diagnostic methods for aspergillosis. And we also have to remember that the climate changes result in global warming, and this disease likes a warm climate, and we have invasive aspergillosis with people with severe cases of suppression of immune system, and these cases account for 70 to 90% of mycosis. We also have chronic aspergillosis with people with bronchial asthma, but we will talking about chronic aspergillosis that is registered in patients with slight or moderate suppression of the immune system, and according to various data, 15 to 90% of patients with final post-TB changes in lungs demonstrate development of chronic aspergillosis. As to the frequency of chronic aspergillosis in the world is 3 million cases worldwide, and more than 1/3 of these cases are post-TB cases, and the frequency is from 1 case per 100,000 of population in Europe and the United States, and up to half in the African countries. Chronic aspergillosis can be subacute. We call it chronic necrotic aspergillosis, and it's more typical for invasive, for acute stage of aspergillosis, and it results in a high lethal outcomes. Then we have saprophytic forms of aspergillosis. We're talking in this case about aspergilloma and chronic cavitar lung aspergillosis, as well as chronic fibrosis and modular aspergillosis, about which we are going to talk. So what are the factors contributing to development of aspergillosis? First, we have the cavities developed in lungs after tuberculosis. On this slide, you can see a lot of other diseases that result in creation of cavities in lungs, including COVID as well, and we saw those cases already. And I would also like to mention that colonization of cavities with micromycetes is facilitated by the process caused by tuberculosis and chronic processes. After TB treatment, every 5th patients in the US and every 3rd patients in South and East Asia develop chronic aspergillosis, and every 4th patient in general demonstrate developments of aspergillosis. First of all, we should also mention other factors contributing to development. We are talking about diabetes, hyperglycemia that suppresses development of complement. Then we have mycelia developed in the air when a person lives for a long time in the room with mycelia on the walls, and when people work a lot in rural areas, then archaeologists, people go into caves with bats, garbage collectors. These are people working in the environment, contributing to development of aspergillosis. Now I would like to demonstrate the difference between chronic and acute forms of aspergillosis. So we see several pictures here with acute stage. In the center you can see the changes resulting from development of mycelia in the lungs, and we also have this change of color as surrounded by the areola resulting from swelling or blood infusion. And this picture can be seen during the first 10 days in the case of acute aspergillosis. After 10 days, we have necrotization of this central part with fungi, and we see this crescent picture, which is formed by the air in the lungs. But this crescent symptom is not typical for aspergillosis, and it can be seen in the case of other infections like mycobacteriosis and cardiosis. And then aspergillosis. You can see two pictures from computer tomography, and they are different from the pictures I demonstrated before that are typical for acute aspergillosis. In one of the cavities, the fungi start growing, and you can see the system the picture typical to the bread covered with fungi, and you can see on the right picture how this fungi layer looks in real life. Then we have chronic cavitary and fibrosis aspergillosis. Then on the left you can see numerous cavities, and on the picture below you can see this fungi layer. On the picture to the right you can see big cavity with some content in it, and you can see that the walls of this cavity are rather thin. And you can see this picture below with a picture with almost total destruction of the right lung surrounded by fibrosis tissue that demonstrates that the process is still in a rather active stage that requires treatment, unlike the right picture above. Then we have chronic nodular aspergillosis. You can see this pleural reaction and thickening walls. On this diagram, you can see the big white area that demonstrates the number of cases with cavity aspergillosis. A gray area demonstrates the share of patients with simple aspergilloma, and the N circle demonstrates individual cases of nodular aspergillosis, and all these changes are usually, the cases are usually mixed, and very seldom we only see chronic aspergillosis alone. TB and chronic aspergillosis have a lot in common because first, these are chronic progressive diseases that in fact destroy the lungs. So they have a lot of similar clinical symptoms such as tiredness, loss of weight, coughing, subfever, and coughing with blood, and they have X-ray symptoms that are very similar with the formation of cavities with some content, pleural changes as well. So authors from Africa analyzed all publications describing clinical characteristics of patients with chronic aspergillosis in Africa. And as you can see, the lower part is hemoptysis or coughing with blood. Then they have pain, chest pain, coughing, and other symptoms are less widespread, such as night sweat, bronchorrhea, then recurrent lung infections and fever from 1 to 4%. And even when we look at the clinical and X-ray pictures, we still can differentiate tuberculosis and chronic aspergillosis because lymphoadenopathy, miliary and pleural effusion are more typical for TB, and fever is more typical for TB as well. For chronic aspergillosis, we see a cavity with aspergilloma. Then we have pleural thickening and paracavity fibrosis. And some of the authors says that there is no cavity and no pleural thickening. Then 100% sure that this is not chronic aspergillosis. So chronic aspergillosis is more severe, characterizes a more severe course of TB because it results in frequent respiratory syndromes in patients. And in Ghana Republic, 50% of patients with TB also have chronic aspergillosis, and very often people who had TB, sometimes they have erroneous bacteriological result. So that is a result of the lack of knowledge, the result of the lack of the possibility to have computer tomography of lungs, and the lack of possibility to find immunological data. We do not have a lot of cases of post-TB aspergillosis, but we have a picture of a patient. You can see on the right side there is change in the lung, and a computer tomography confirmed aspergilloma in this area with all the respective symptoms that we were discussing. Then we have another patient with relapse of TB, and you can see that in the right lung below, on the right picture, you can see a small cavity, newly created cavity, that is connected to the pleural, and you have this pleural thinking. So GeneXpert demonstrated that the patient had TB mycobacteria, and the positive test for MG was also positive. Then we have a woman aged 45. She was coughing with blood for 3 months, and then we used GeneXpert for carrying out respective tests, which were negative. So she received anti-TB therapy, and after that we carried out a lab test on antibodies, and she received traconazole with good results. Then we have another girl, 18 years old, from Uganda. She was coughing for 2 months. Before that, she received treatment from TB, against TB twice. So you can see that her right lung is now totally replaced with fibrosis tissue. So she again received anti-TB treatment, and then intraconazole was administered. They reached a positive result. So how do we diagnose chronic aspergillosis? So we use computer tomography, we use clinical examination, then we use all possible methods to exclude TB from diagnosis, because these two diseases are very similar, and lab methods, which I'm going to talk about, are used as well. And the golden standard in diagnosis is to identify this IgG and IgM antibodies, and this is a highly sensitive test that gives almost 100% accuracy of results.
And we can say that with patients, if you have immunosuppression, so people who have HIV, so this test often is quite used during aspergillose. And also I have to say a few words about culture research. Unfortunately, the accuracy is about 50%. But if we receive the culture so then most probably we will find out aspergillus, also galactomannan test, which can identify Aspergillus fumigatus. We can identify patients with acute aspergillus, but if we have some suspicious cases, then we can use from prong sample. And these are our examples. We work together with our distinguished colleagues from the Department of DRTB, and we have worked with 20 most difficult cases, and we found out only 2 patients. So fortunately, in our less southern areas, so we don't see this disease very often, fortunately. How to treat aspergillosis? Aspergillus is still sensitive to itraconazole, which is less expensive than other drugs. And voriconazole is quite effective, but it's expensive. And also it can provoke photosensitization. We need to remember that we have some dangers of using a few drugs at the same time. So, for example, if we need to treat patients with comorbidities, we need to be very careful. And we can define the dosage for aspergillosis, and so usually treatment lasts up to 12 months. It is individual, and we can define the treatment is effective based on clinical symptoms. So it can happen in the practice of physiologists and pulmonologists, and it's possible to treat. Thank you very much. Thank you very much, Ms. Olena. It was very interesting, especially those clinical examples which were provided, where you showed us a combined infection of tuberculosis and DRTB, moreover, and aspergillosis, and how difficult it is when you have 2 active diseases at the same time, and the patient requires 2 types of treatment. And dear colleagues, now we are going to move to a short discussion. We have a few questions in the chat. Let me find them. And the first one to you, Ms. Olena, I think that's addressed to you. One participant would like to know about differential diagnostics of destructive changes in lungs. I think what advice, what algorithm of the differential diagnosis can you provide if there is destruction? Most probably, it is meant that if there is no bacterial emission, so of course it is a problem. And of course, in the first place, we can work with lab tests and especially of immunochromatological test. Fortunately, we have this test in the country and in our institute. And of course, we can have additional methods of Hallertau-Manon test, which also is accessible in our country. And of course, histology. If we suspect, but we cannot diagnose, so then we can go with histology. So then 98% of cases we can be sure. Thank you. There is another question, and it will be to Ginta from Riga about mycobacterioses. I think that the first part of the question is about the cost of the test for mycobacteria, non-NTM. If you know the price, how much it costs in your country, so how much it costs to do the testing for NTM, or whether it actually free for patients.
Did not understand the question completely, but I could have guessed that it's a question how we can identify those NTM species and about the can you translate?
Яка вартість дослідження?
Вы можете мне спросить на русском языке, но извините, на украинском я не поняла вопрос.
Какова цена обследования в Латвии или...
Спасибо. Я могу ответить на русском языке или на английском, как вам лучше. Значит, в принципе...
Как вам удобно.
Да. В принципе, значит, все больные, у которых есть, скажем так, подозрение на туберкулез, в том числе, там включается и...
So for all patients, if we have the suspicion for NTM or tuberculosis, so all the testing and treatment is free for patients in our state. But I think that because the fact that we have coverage for TB and the testing, but we don't have that many patients with NTM. For example, the previous year, that was maybe 47 patients who were identified with species of NTM, but we don't register these patients officially, even though our lab is the main lab which does research on NTM in general. But if we have more patients like this, maybe they will need to pay to some extent. Thank you very much. And the second part of the question. So if the patient has proven NTM but without any clinical symptoms. This is a very relevant question. So, of course, I had only 15 minutes for my presentation. I couldn't include everything in my presentation. So this differentiation from tuberculosis, and it's very important that when we have mycobacteriosis, so we have some clinical criteria. So we need to prove that this disease, so basically the patient needs to have certain criteria, including symptoms, at least 2 positive culture, either on bronchitic liquid or sputum, and also changes on CT. But even now we need to make a decision whether we need to treat or not. So it is considered that if we have a fibrocavitar form, then, of course, we treat these patients, and usually they do come with complaints. But those patients who come with bronchiectasis and if they have some other maybe lung diseases, so these patients usually it's just maybe we need to monitor, maybe we need to optimize the treatment for bronchiectasis because usually treatment is quite long and not always effective. And I have another question to you. How often do you do surgery if you treat mycobacteriosis? Thank you. I probably cannot give you exact percentage, but of course, we always monitor all patients. They start to be treated in hospital, then outpatient, and sometimes if there is no positive dynamic a few months later, and the patient can be treated surgically based on his other absence of other conditions. So if this disease is more localized, because of course if these are with big cavity and to both sides, so of course in this case we cannot do surgery. But I think it's very important to understand which type of species provokes the disease, because, for example, Gansassi mycobacteria, it responds well to regular treatment, but it requires also long treatment, 6 to 8 months, until we have some improvement. And but it still means that the patient won't need surgery, so it's very individual. Thank you very much. It was very interesting questions, and thank you very much for your answers. I think that colleagues who asked those questions, they received the answers. Thank you very much, and I hope that it's not our last meeting. Maybe we will meet at some other conference where we can discuss different questions on lung diseases and share our experience. Thank you very much for joining us and participate in the conference and join the discussion. Thank you very much. Thank you for inviting me. And I have two small questions. One. So the first question is to Ms. Evgenia about sarcoidosis. In your experience, how often sarcoidosis doesn't need treatment but just monitoring, even if we find some changes on CT and the changes on... So do we always need to treat that?
Thank you for this question. And everything here depends on the stage of disease. When it's stage 1, there is normally no need for treatment in 90% of cases. If it's stage 2, then it's approximately 50-50. So for 50 patients, we continue monitoring of the condition of the patients, and to 3 or 6 months, if we see positive dynamics in the process, then there is no need for treatment as well. But unfortunately, half of these patients develop further deterioration of the process and require therapy. Third stage usually has respiratory symptoms and general symptoms and the decreased function of external breathing. So patients, their number is lower, but all of them need therapy. Thank you, because this is a very important question. Physiologists usually have the situation what they have to decide what to do, to monitor or to start treatment, because treatment is quite lengthy. The drugs have a lot of adverse effects. And I have my last questions for Lisa. You were talking about a lot of clinical cases, and on the one hand, it was very interesting, and on the other, it was scary because there are a lot of clinical cases. We would like to have fewer of them. So over the last period, do you have more clinical cases? And if yes, then what could be the possible reason for that? Maybe we have just better diagnostics, or do we have more cases of carcinomatosis? Thank you for this question. Yes, patients are from our clinics. That was a longer period of time, so we were collecting these cases specifically. In principle, it's better diagnostics, yeah, so we have better rate of detection, and this is an advantage for our patients because the earlier we find the disease, the more chances they have for to be cured. And I think it's also a result of the situation that patients do not always come to us in time. So when they have symptoms, that is a sign of a rapid progression and a bad forecast for the patient. So probably we should think about doing some preventive examination, because when we ask the patients when they had their last X-ray examination, they say it was about 5 years ago. So we would like to have more preventive examinations. Unfortunately, yes, we have a higher rate of disease and better diagnostics because we have this computer tomography, and that improves diagnostics. Thank you for your answer, and I would like to thank all our speakers. Again, it was an extremely interesting session for me. I'm a physiologist and I deal with TB patients most of the time. It was very interesting for me to listen to our colleagues dealing with other lung diseases, and they provided good comprehensive information for us about diagnosing these diseases and differentiation from tuberculosis. So this is the end of our second day of the conference, and the last session is completed. So we continue our work, and those who want to join the master class will have to leave this conference. And if you want to join the master class, you leave the stream and you go to your email box and you use the link that was sent to you with the topic of registration for the master class. So for you to be able to listen to the masterclass, you leave this conference and you use another link that was specifically sent to you for joining the masterclass. So we apologize for this delay, for this half-hour delay. So 3 to 5 minutes for us to organize everything in terms of switching streams, and after that we will return to you. Nastya told me that we will need up to 10 minutes to change streams, and we will do our best to return to you as soon as possible, so stay with us. So leave the conference and join the masterclass stream. Thank you for your attention. Those who are not going to join the masterclass, we wish you all the best for the rest of the day. Have a nice evening, peaceful sky, and calm evening with electricity and light and heating in your homes. Glory to Ukraine, and see you tomorrow. Thank you for your attention.